This conference will now be recorded.
All right, so let's cover Chapter 7, the human body. So a lot of this stuff should be review for everybody here. Going over cardiac, respiratory system, things like that. The human body chapter does not go in depth in the systems itself. We're going to have other ones coming forward, like cardiology, respiratory emergencies, and things like that. But you are going to get a little bit more in depth with this stuff. Some of you have been practicing for a while, may have a higher understanding, or if you've done any more of your own Con Ed throughout the years you've been in EMT, and things like that. I'm going to silence my phone really quick. One second here. Let's see. All right. All right, let's get started. Right button. All right, so, excuse me. Move this down here, and there we go. My goodness. So obviously, gross anatomy includes body parts visible to the naked eye. What we're going to see are visual assessment. So we're learning more about how the human body works, but the thing is it's going to be more of how we're going to do the assessment to assess those things we can see and how we're going to assess the things that we cannot see. We're also going to look at, remember, gross anatomy also includes body parts that are generally visible. A microscopic anatomy involves components of the body that are small, often visible through a microscope. And then obviously we talk about physiology, which examines the body functions of the living organism. We also have to understand pathophysiology, which we'll get into a little bit later, on how these systems actually work. And you're going to take that pathophysiology, the human body, something we learn throughout the program, and how that interacts with medications. Remember, as an AEMT, we have a decent amount of these are the medications that we're going to be utilizing that will actually have effects on the body. So one of the things I want you guys to remember is cause and effect, and we will hit that a lot as you go through the program and how the body reacts to certain things that we do. So let's talk about the cell, okay? We're a little more in depth of the cellular structure here. So remember, the basic functional unit of the body is our cells, which are extremely varied in the shape and function. So remember this, with the cells, as they mature or differentiate and become specialized to perform a specific function, right? And we're going to go into the next slide and talk a little bit more about the cellular structure. With that, groups of tissues that all perform irrelated jobs from these organs. This is more of the breakdown. The series of organs also working together make up the body system that we have. A lot of things that we do are really based on that cellular structure and how things work. Like I said, we're going to kind of break this down even more in detail as we go through. But this is basically the cell structure here, as you can see. There are two general classes of cells. There's sex cells, and then there's the somatic cells, right? Two different types, general classes, I should say. The nucleus contains the genetic material and controls the activities of the cell that's there, right? So you can see where the nucleus is located here, the nuclear membrane, the goodness, I can't speak, and the chromatin. We have lysosomes, which are more destructive cells. We have the cytoplasm over here. The mitochondrion, which is the powerhouse of the cell. Shouldn't go down through all the different parts here. I don't want to get ahead of myself as we go. Go to the next cell here. Or sorry, the next slide for the cell. So breaking down the cell membrane, looking at this here, which allows movement in and out of the cell. This is going to be very important for us because we give medications that help push things out and bring things back in. What are some of the electrolytes that we deal with through the system? What can you guys tell me about that? How are we moving things in and out of cells? I got sodium. Yep, there's more. What else we have? Sodium, calcium, right? Yep, water.
Potassium.
Potassium, yeah. Sodium, potassium, calcium, magnesium, right? All these things, electrolytes that help keep the body functioning appropriately, right? And if we have a deviation in those, what can happen?
Throws off homeostasis.
Right, which then causes what?
Would it be like a metabolic imbalance?
It could, but also then has what kind of complications to what body system?
Heart, liver, lungs.
All right, so cardiac, right? Cardiac system, respiratory system. These are all different things, the systems that are going to be affected if we have a lack of a specific electrolyte. So this kind of breaks it down even more now into the cellular structure, where we have molecules that form the pathways to allow movement into and out of the cell. Things get moved, right? So to kind of break that down even more, how do things get moved? How do liquids get moved from one part of the cell to the next? What is that called? Talking fluids. Fluids moving.
Homeostasis.
Homeostasis is like the even playing ground where we should be at. What is it called when you move something from greater to lesser concentration? And more specifically, a fluid. We're talking about things that move in and out of cells. Things moving from.
Osmolarity?
What was that?
Right, osmolarity, is that right? Or osmosis?
Yeah, osmosis, exactly. Yeah, exactly. That's what we're looking for, right? And that moves from areas of greater or lesser concentration to provide that homeostasis that Sean was talking about. Sean has said that. That breaks that stuff down, and it moves it over from one to the next. And then we also have gases as well, and we start breaking into the respiratory system, right? And we have the gases moving like carbon dioxide, oxygen, everything else, and that's done through what? Once we have an understanding of how a gas moves and what the name of that is versus how the fluids move, this will help understand how the cell actually works in moving our electrolytes back and forth and or our oxygen and carbon dioxide. So what is it called when you move a gas from a greater to a lesser concentration? We have osmosis for fluid. It begins with a D. Caitlin is correct. Diffusion, exactly. So we have diffusion. So let's go more about osmosis, diffusion, how we understand that, gas versus fluid, how we move things back and forth through the cells, right? Now let's talk about the cell membrane and get into the cell there. I kind of wanted to go ahead, but then I want to come back, and everything will come back into a big picture, all right? So with that, with our cell membrane, also called the plasma membrane, talk about molecules that form pathways that allow movement into and out of the cells, or molecules moving back and forth. The pathway then allows signals from the outside of the cell to be detected and transmitted inside. Okay. With that, the cell membrane is also extremely thin and delicate. There are tiny folds, as you can see, on the surface to help increase surface area. So if you can see the mouse on the screen, the tiny folds will help increase the area. They're composed by a bilayer containing phosphate and fat molecules called phospholipids. And it's also semi-permeable as well. This allows our bodies to function. We have to have a decent cellular structure in order to be able to move stuff around. What other cells do we have? Like, remember, we have white blood cells, red blood cells. There's cells throughout the entire body that move stuff and move things around that help us meet that homeostasis. All right, so cytoplasm is a fluid-like material in which the contents of the cell are contained. Cytosol is the fluid portion of the cytoplasm, which contains mostly water, as well as some glucose, amino acids, fatty acids, ions, lipids, proteins, adenosine triphosphate, ATP, and also waste products as well. Where does all this stuff actually play a part in, though, right? Well, we're going to get more into that later when we start talking about our nervous system, our different systems, like the parasympathetic and sympathetic nervous system and how our body creates neurotransmitters and everything else. This will all come into part of this chapter as well, but understanding how this stuff actually works. And many of the chemical reactions necessary for life take place within a cytoplasm. We have to have these chemicals in place, right? If we have a deviation, then we have patients that go into shock. The organelles accomplish tasks related to cell structure, growth, maintenance, and metabolism. So organelles, let's talk a little more about the organelle part of it. Right, organelles have specific actions that help with the cell to carry out its activities. We have centrioles, which are during the cell division, when they divide. Centrioles form a spindle-shaped structure needed for movement of the acid, which then helps. I'm just drawing a blank of the name. It's a DNA strand. I'm trying to remember the name. It's a deoxy something. I'm drawing a blank. Having a moment today. I think it's like deoxyribonucleic. I have that pronounced right.
Deoxyribonucleic acid.
Thank you. I'm having a moment today. I'm not too long and too much work. All right, so DNA strands. So with that, the cell division then requires a pair of centrioles. You have flagella and cilia as well. We'll talk more about those moving forward. But with those cilia and flagella, my goodness, extend from certain cell surfaces. The cilia move fluid over the surface and tissues as well. The flagella propel the cells to which they are attached. Ribosomes are composed of proteins and RNA as well, which is ribonucleic acid. With that, they start forming proteins. Endoplasmic reticulum is the network of paths through the substances and protein moves. There are two different types. We have smooth, which lacks ribosomes, and rough, which has ribosomes in them. All right, as you can see down in the picture here. So let's get a little more about the organelles and let's move a little more with this one here. So the Golgi apparatus, that deals with proteins synthesized on the ribosomes. There are three main functions with that. One is concentrating and packaging secretions that are released for secretion out of the cell. Two, packaging special enzymes inside vesicles for use in cytosol. And three, renewing or modifying the cell membrane. Lysomes dispose of cell waste using enzymes to break down nutrients and foreign particles. Microfilaments compose the proteins actin and myosin, which then provide cell movement and contraction via the interaction with the actin and myosin. The mitochondria, which is the powerhouse of the cells, have double membranes that play the central role in the production of energy. The outer mitochondrial membrane is a smooth membrane. The inner mitochondrial membrane has a series of folds called cristae. The central fluid-filled activity inside is called the matrix. How are you guys doing so far? There's a lot behind all this. At the advanced level, getting in depth. I'm trying not to go super in depth with all this stuff here, enough to be able to get you through for the advanced level. I don't want to go above and beyond this one here yet. I want to hit more of this when we start getting into the medications that we administer and how that works with the mechanism of action, how it breaks it down and serves the bodies to a purpose of treating the patient. All right. So the peroxisomes contain enzymes that speed up and may many biochemical reactions. Then there's thick filaments, which have massive bundles of, excuse me, I can't even pronounce words today. The subunits compound of myosin and as well. Then you have the vesicles, which are sacs that are formed when a part of the cell membrane kind of folds inward. Kind of wanted to. Oh, wrong button. Hold on a second here. I kind of wanted a better breakdown for you guys to see it, but I don't see it on the slides at all. I was hoping there would have been one ahead of time. All right, so the nucleus, which is the largest structure in the cell, serves as a control center. That's where everything happens, which contains the genetic instructions needed to synthesize the proteins that determine the cell structure and function. The structure consists of DNA and other various proteins that are there. Inside the nucleus is a fluid called nucleoplasm that suspends the nucleus in chromat. Hi, Evan. Welcome back. Stand by 1 second. Should take a look at something really quick. I want to see who else joined the class other than Evan. All right, moving forward. So the life cycle of the cell, regulated by a stimulation from hormones and growth factors, most human cells divide between 40 to 60 times before they die. The life cycle of the cell, the interphase, cell division, which is mitosis, cytoplasmic division, which is cytokinesis, and then differentiation. Ooh, there we go. All right. So the interphase is the period of preparation to divide, as it's getting ready to prep to split apart. The cell manufactures new living material and replicates its own genetic material with that as part of the interphase portion. Excuse me. The cell then the cell division and the cytoplasmic division, as it gets ready to divide or two, is meiosis and mitosis, cytokinesis. Sounds like I'm having a stroke talking about these words. Are different types of cell division. So meiosis reduces the number of chromosomes by 1/2. All right. So this occurs in production of the eggs and the sperm. This is kind of the production occurring. During mitosis, the cell duplicates itself into daughter cells and then what they call identical copies. The cytoplasmic division, so the cytokinesis, begins during the second phase of mitosis. Did I lose anybody yet? Are we kind of making on with this? Doing okay? Good. So the cell membrane then constricts down to the middle portion of the cell and divides into cytoplasm. At this point, two newly formed nuclei then are separated, and half of the organelles are distributed into each new cell. That's interesting, Mike. I never heard of that one before. So the differentiation part is the process of specialization of cells, which makes a cell unique at this point. So it's, hi Jen. So a stem cell can divide repeatedly without specializing, which can divide into identical daughter cells or divide so that one daughter cell becomes partially specialized, which is a progenitor cell. So cell divisions with cancer. Cell division and growth occur at approximately the same rate as cell death. So when a cell division and growth occur at a higher rate than the cell death rate, then tissues start to enlarge. Then we have something called a neoplasm, which is a mass of tissue produced by an abnormal cell growth and division. That mass then turns into a potential for a benign tumor when it remains within the epithelium, which seldom becomes life-threatening and can usually be surgically removed. But when it becomes malignant, a malignant tumor, then it spreads to the surrounding tissue in a process called cell invasion. With that, many may result in a malignant cell traveling to other organs or tissues to establish secondary tumors called metastasis. Malignancy occurs when a normal gene mutates. Cancer cells then change the shape as they grow and gradually resemble normal cells less and less. I was hoping there'd be some decent pictures of how this stuff changes. It'd be easier to explain if I can actually show you pictures of these. I'm surprised I didn't put these into the slides. Presence of tumors or tumor cells stimulates the growth of new blood vessels. As metastasis increases, organ functions start to change. So let's go to the next slide here. Cellular respiration. This is kind of important for us because this is how we get oxygenated. Glucose moves back and forth. All right, so cellular respiration, where the cells use glucose and oxygen to release energy from an organic compound. And I'll show you guys that in the next slide, which requires three types of reactions. So you have glycolysis, the Krebs cycle, and the electron transport chain. Number two, the result of the cellular respiration is carbon dioxide, water, and high energy molecule ATP, which is adenosine triphosphate. Glycolysis occurs in the cortisol, or sorry, it's not cortisol, cytosol, and the cytoplasm. We'll talk about cortisol stuff later on. This invades a series of so this involves a series of enzymatically catalyzed reactions in which glucose is broken down to yield lactic acid and pyruvic acid as well. This does not require oxygen from an anaerobic metabolism. If oxygen is present in the right amounts, pyruvic acid can enter the more energy efficient pathways of aerobic respiration. Remember that aerobic reactions yield as many as 36 adenosine triphosphate ATP molecules per glucose molecule. Okay. So as you can see, a lot of talk about cellular movement. If we have an imbalance, the patient can go into shock. We have to be able to recognize that imbalance, looking at the vital signs that we have in front of us, cardiac monitoring, cardiac arrhythmias. All these things can show signs of cellular respiration or cellular structure change. So you guys have been in the field for a little while. Instead of talking about more in-depth stuff here, which we will talk to you about here in a second, let's kind of cover certain things that we can do as testing in the field to see if we have different types of imbalances. What are some of the tools that we do carry that can help look at some of these imbalances we can come across?
Blood glucose level.
Yep. Checking the blood glucose. What else?
O2 sat, capnography, and cardiac monitor.
Yeah, excellent. All great tools that we carry. But once again, I see George putting down capnography. Awesome, George. So we
How about a
mentioned.
temperature?
Go ahead.
How about taking a temperature?
Yeah, absolutely. Can we tell if the patient has an infection with a temp? Yeah. So taking a lot of this stuff aside, we can measure, we can do cardiac monitoring. We can look to see if there's any irregularities, PVCs, PACs, PJCs. I'm throwing this stuff out now. You will learn what those are in the class later on during cardiology, right? We can see the different irregularities. We're going to see if they have if they have any pauses, if they have wide or narrow complex, if they have any kind of. We can see a lot of this stuff that could be cardiac in nature or could be something at the cellular level, electrolytes, things like that, that are off, causing these different changes. If we have cellular respiration, T waves, exactly. So Mike mentions T waves. What about T waves specifically? And by the way, looking at T wave, which I want to see if anybody can actually bring that up here, or what we're looking for specifically in that T wave, can only be done in a 12 lead. So what about the T waves?
If they're spiked or they're depressed.
Yep. What does that mean? If they're tall peaked, what does that mean?
That's the hypokalemia or natremia, one of the two.
Natremia Na would be sodium, right?
Yeah.
So hyper K being kalemia,
Yeah.
would be potassium. So if you have a patient that has peak T waves, like Mike just mentioned in the chat group, exactly, the patient has high potassium levels. Okay, if they're hypokalemic, you're going to have those flattened T waves in the 12 lead EKG. George, are you able to talk, or are you just doing text?
No, I'm able to talk.
Perfect. So you mentioned capnography. What does that measure?
The amount of carbon dioxide that is being expelled.
Exactly. It measures the amount of carbon dioxide, so CO2, right? So, like Matt O'Connor's mentioned CO2 in the text box. Perfect. So, what about capnography? What's the normal range for us?
35.
35 to what?
35 to 45.
Yep, perfect. Mike got 35 to 45. Those are normal ranges. What happens if they're too low? What does that mean?
Means not enough carbon dioxide is being expelled.
Yeah, not enough coming out, which puts them in what type of state? Alkalotic or acidotic state?
Wouldn't it be acidotic, I think?
Right. So they're acidotic, and if they're too high, they'd be alkalotic, right? So let's take that one step further. This is the fun stuff. This beats all this cellular respiration things that we kind of need to know. This is the fun stuff here. We have alkalosis and acidosis, right? Now we're getting into acids, acid-base balance, and how we're going to be able to fix things and be able to pick things up in the field. What is our normal pH?
Wait, Kevin, which is which again?
Which part are you asking?
The acidotic and Acidotic is too high, correct?
So a patient, let's put it into a scenario instead to kind of explain it, right? If a patient's in cardiac arrest, right? And we're going to get high end tidal readings eventually. The patients in cardiac arrest, are they metabolizing? Are they moving things around?
No.
No, right? We're not in cardiac arrest, no CPR being done, no medications being given. Someone drops within the cardiac arrest, everything starts to drop, right? Our end tidal is going to be low, correct? Right. So what happens if we get pulses back? What's the first thing you're going to see before you even get pulses? What's going to start happening? It's right here on the.
You're gonna see capnography and you're gonna see a rhythm come on the screen.
You know, it might not even see a rhythm. It might still be a systole.
You
Minutes.
see the capnography come up, or the ETCO2 come up to above, what is it, 9 or 12, something like that?
So
Above.
so let's go back to cardiac arrest. If you have a cardiac arrest and you put them on end tidal, you intubate them, King Airway, whatever, okay, even with a BVM, and their end tidal is showing greater than 10, the chances of getting pulses back are a lot higher than less than 10 based upon studies. Now, the patient, okay, it might say blow off CO2, exactly, you're blowing stuff off. So what's going to happen is you're going to get cellular respiration moving, right? They're going to blow off all that acid, right? And what's going to happen to your end tidal? It's going to spike, right? It's going to blow right up. 50s, 60s, 70s. I've seen it as high as in the 80s before, right? All that acid is being blown off. All that carbon dioxide is coming out all at once. You're going to see that big spike. That means you have ROSC, okay? That means that cellular respiration is happening. Gases are moving. Fluids are moving. We're getting pulses back. We have electrical conduction, okay? All this is moving as one big part, right? We can talk about cellular respiration all day, but until I can put it into a perspective of what's going to happen on a scene, this is what we're seeing, right? So if a patient is breathing too slow, let's say they're an overdose patient, okay, and you get there and you put them on end tidal through nasal cannula, and the respiratory rate is 6. Would you expect to see a higher end tidal or a lower end tidal?
A higher?
Higher, exactly, because now they're not blowing off carbon dioxide like they should be, right? They're blowing off. They're not retaining enough. I should say, not blowing off, but not retaining enough. Therefore, they're going to have higher end tidal. The slower the respiratory drive, I mean slow, like low respirations, the higher you're going to see end tidal readings. And I'm talking like greater than 45. I'm talking like 50s, 55. If the patient is hyperventilating and they're tachypnic, breathing 40 times a minute, where would you think you would see the end tidal?
Then it would be lower because they're not exhaling enough to, or they're exhaling too much.
Which means they're retaining, right?
Correct.
So rapid respiration, low end tidal, low respiration, high end tidal. And in order to meet homeostasis, how do we fix it? Inadequate gas, exactly. Inadequate gas exchange. This is all important cellular respiration stuff. How do we fix this problem?
We're going to try to get the patient to slow down their breathing.
And how do we do that?
We could use the needle effect there. We have them blow into the cap. You can talk them through it.
So you talk about the blowing into the cap thing. Are you talking about a patient that's an SVT trying to stimulate a vagal response?
Kind of like that. Or we can actually bag them and actually have them kind of work with us while we bag them.
Let's go with that one there. And Mike Ball put a good point. Adequate breathing with coaching, adjuncts, and oxygen, right? If we can't get it with coaching, then we have to do it by helping them and assistance, right? That's when we start bagging them. So exactly, Sean. Mike has it right too, though. Coaching first, right? Oxygen, bag them. Let's get their levels back down to homeostasis. Okay. Now, if they have problems breathing, what's another device that we can utilize to help with this? If we don't have the ability to bag them, or we do, so they're able to maintain their own airway. Tondra has said CPAP. So I'm telling you about cellular respiration. We're going over the ins and outs, how this stuff works. But how do we fix it? We recognize it through testing. We need to fix it through the testing. What can we do at our levels? CPAP, BVM, end-tidal CO2 is all basic level assessment. BLS. It's amazing. Now I'm talking about state of New Hampshire and National Registry, okay? Other states can't use end-tidal at the basic level. New Hampshire, you can. And we can see this stuff in the field. We do vital sign monitoring, pulse oximetry, end-tidal CO2 monitoring, cardiac monitoring, right? This all helps you break stuff down to see what potentially could be wrong. I want to say, was it Mike? I believe it was you that mentioned about the T wave. Yeah, it was. Okay, I went back to the notes. Perfect. And then Evan kind of more elaborated a little bit more in detail on it as well. This is what we're seeing, right? We can talk all day about cellular respiration and what's going on, what's being released, right? Glucose and oxygen release energy from organic compounds. Great. How do we fix that? We recognize it. We see it. We see it on the end-tidal readings, waveform capnography, right? What would happen if I said to you guys, on an end-tidal readings, end-tidal is phenomenal, okay? If I said you saw a shark fin, what would that be? I see, yikes. Yeah, Jaws is coming to get you. If you saw shark fins on end-tidal, what would that be? What do you
It's like, it's
know?
not good, I'll tell you that.
It's definitely not good. And we can, and believe it or not, Rosa, we can fix that at the A level in the field. How do we do it?
Would the shark fin be COPD?
It would be. You gave me a disease process that causes it. Now let's break that down even farther. And yes, we're still talking about cellular respiration. That's why I haven't stopped talking about all this other stuff, because we're still in the same part. Break it down even farther for me, Matt. Keep going. I like this. What is COPD?
They're oxygen retainers, aren't they? Or
Okay, they do retain carbon dioxide, not oxygen.
yeah, that's it.
Right?
Carbon dioxide.
I knew you were going with it. What does COPD stand for?
Chronic
Chronic
obstructive pulmonary disease.
Yeah, that's it.
Chronic obstructed pulmonary disease. What's the second word? Obstructed.
Obstruction.
Go with that. Keep going.
All right, so their pulmonary arteries or whatever are
No,
obstructed, right?
not arteries, right?
Um,
Talking about the lungs. We're talking about cellular
uh,
respiration, right? Moving stuff around.
would it be decreased permeability in the cells?
Start from the top and work your way down with it. You see shark fin respiration. You got a patient who is a shark fin, COPD, O2 saturations are, let's say, 59%. What's going on?
They have too much carbon dioxide and not enough oxygen.
But it's shark fin, right?
Yeah.
It's not a normal plateau that you normally would see. It's shark fin. What's going on?
Hyperventilation.
Nope, we're not hyperventilating. I mean, they are breathing faster. So let's break this down. Let's start from here.
They're
COPD,
breathing shallow.
right? Let's break down the COPD part of it, right? We'll break right down to the respiration stuff. A patient with COPD has chronic obstructive pulmonary disease, right? With that, if they're having a COPD exacerbation and you start seeing shark fin waveform, what you're seeing is bronchoconstriction, right? Bronchioles are starting to constrict, but that's not what gives you that shark fin waveform. it goes down even farther to the alveoli in gas exchange at the cellular level, right? The shark fin, yeah, Mike, exactly. Albuterol, and then one step further, hypertropium bromide. Giving that steroid along with that bronchodilator will help open that up. Back to the
So,
alveoli.
so you're gonna give them a duoneb.
Exactly. As long as they don't have any allergy to soy products, absolutely. Because hypertropium has a reaction with people that have allergy to soy. It can. All right. Let's break it down though. What's happening is at the cellular level and at the alveoli, with gas being exchanged and being released carbon dioxide, which we talked about in cellular respiration, right? Oxygen in, carbon dioxide out. The alveoli are releasing at different times. If every one of you in this class right now took a deep breath in and a deep breath out, your lungs fill in, right? Oxygen comes into your lungs, passes through the system, which we're going to cover here in a minute, right? Attaches to the red blood cells. Oxygen comes in, red blood cells then bring it back around again. They dump off the carbon dioxide, a breath comes back out, and you expel all at the same time, right? With patients that have COPD, asthma, emphysema, bronchitis, things like that, you see that shark fin waveform. The alveoli are releasing at different times, causing that shark fin versus that upstroke and normal plateau. So we fix it. And the only way to fix it is by giving them dilators and steroids. Does that make sense now?
Yes.
Right? A little more understanding of how COPD actually works, basing it
Yeah, I get it.
right? It's amazing what you can see looking at a couple little boxes and numbers and having an understanding at the cellular level of what medications you're giving and how it works. This is how we fix cellular respiration, how we get that oxygen and glucose to the cells and release energy organic compounds. They are also at risk for higher risk of respiratory failure. Absolutely, they are. Absolutely. All right. And we want to prevent this from happening. And one of the ways to do it is providing them positive and expiratory pressure to keep the lungs open longer, which is PEEP, which is CPAP, to allow the medication to get down deeper into the lungs to cause for better bronchial dilation and better chance of the alveolar release of carbon dioxide, so we can change the waveform from shark fin to normal plateau. And in turn, we'll also fix your end tidal numbers to make homeostasis. Does that make more sense now? Did I lose anybody in what I just told you?
No, I get it.
So the next time, and a lot of this is new for a lot of people, so the next time you respond to a call on a patient that has carbon dioxide, the patient that has COPD, all right, you're going to be like, holy crap, I actually know what's going on deeper than just giving somebody a neb. Everything we do has a cause and an effect, right? If I give somebody a bronchodilator, and we haven't got much into this yet, but everybody's an EMT, so you should have an idea what albuterol actually does, is also a sympathomimetic medication. So you got to remember, there's a cause and an effect to everything we do. We're going to open up someone's respiratory drive and help them breathe better with a duoneb and CPAP and all this other wonderful stuff to make cellular respiration happen and also assist with the release of carbon dioxide. But there's also side effects to the medication you're giving. And a side effect to albuterol is tachycardia. Right? Sympathomimetic mimics the sympathetic nervous system, which has to do with tachycardia. Everything we do has a cause and effect. Everything I told you I mentioned that before. Cause and effect will come out of my mouth quite often because everything we do has an effect of what we administer. The positive effects of albuterol, hypertropium bromide, even to the medic level, utilizing other meds like steroids, like dexamethasone or solumedrol as a steroid, to mag sulfate as a smooth muscle relaxant to help them breathe better, to even CPAP at the basic level. There's an effect to everything that we do. CPAP causing pressure in the thoracic cavity can decrease blood pressure. So you got to be careful of that as well. right? Headache, dizziness, anxiety, palpitations. Exactly. There's side effects to everything that we do, but does this patient need it? And then we can deal with the side effects later. Cause and effect. Awesome. All right. I didn't mean to go on a tangent or go off on a tangent. Is probably a bad word. Off topic with that, but I felt that I was probably going to lose you guys quite a bit in regards to talking about the breakdown of how all this stuff actually works. Right? I want to put that in a real world perspective on how we treat patients. This is what we're here for, right? Is to learn the stuff from the book, but how to treat a patient and what we're planning on seeing, what we're doing, right? That's what we do here. And everything I just explained to you is pretty much on this slide and how we move stuff. So the figure shown shows anaerobic metabolism versus anaerobic metabolism. So during the process of anaerobic metabolism, which occurs in the cytoplasm, the breakdown of the glucose results in lactic acid. During anaerobic metabolism, which occurs in the mitochondria, the breakdown of glucose results in carbon dioxide, water, and adenosine diphosphate. So who wants to take a stab at this question? We want to jump in? I'll give you the question. Who wants to try it? Why would we see an increase in lactic acid with a patient who's septic? Who wants to give it a stab? Anybody want to try it? Why do we have, I see cellular waste, okay. So we talk about the cellular waste product of lactic acid. Why is there a higher lactic acid with that?
Because the body hasn't is unable to get rid of.
All right, so I'll read this off. I just got Kenny's message about you driving. Thank you. So septic patients not perfusing well. Septic patients do not perfuse, right? I'll tell you why in a second. Again, cellular level. Cells have to use alternate means to oxygenate and get the energy, which lactic acid is the waste product of, right? So we have a higher level of lactic acid in the system, which is actually really bad. We got to get that out of the system. And how do we do that? We hydrate them. We give them fluids. At the advanced level, it's fluid, right? The solution, exactly, right? So what's happening is the patient who's septic, right? We talked about this here, the cellular respiration stuff and all that lactic acid buildup and not being utilized appropriately and whatnot, right? With this happening, okay, the patients are becoming more dehydrated. They have potential elevated temperature. They're breathing faster to blow off the gases, right? They have an elevated respiratory rate. Their blood pressures are dropping, which means their MAPs are probably below 64, okay? So you're going to have lower end tidal. Your end tidal is going to start dropping below 32. These are all indicators
It's a
of.
holiday weekend. That's why.
Matt, you're still unmuted.
Oh, sorry.
That's good. No worries. All right. So with all this happening, our patients are becoming very dehydrated, which then in turn makes them tachycardic as well. Now you have buildup of lactic acid because the body's unable to break that stuff down. To fix it is fluid. We have to hydrate them. In order to hydrate them, we're not talking 100, 200, 300 milliliters. We're talking 3, 4, 5, 7 liters of fluid. Liters of fluid. That's what these patients actually need. And what they actually recommend, based on some of the newer studies, is rotating lactated ringers and normal saline liter for liter back and forth. And in hopes that will turn this patient around. If not, then they have to go to pressors to maintain that, along with multiple antibiotics to help clear out the infection. The infection is happening, and you're getting that widespread vasodilation because of bacteremia getting in the system. So bacteria gets into the bloodstream, causing a wide systemic vasodilation, causing that blood pressure to drop. All this stuff plays in a factor and can easily be fixed with antibiotics and fluids, as long as it's caught early enough. And these are things that we miss. We're going to talk more about sepsis later on. All right. So the Krebs cycle, also called the citric acid cycle or the tricarboxylic acid cycle as well, or the Krebs cycle. They're a form of an anaerobic metabolism where the sequence of enzymatic reactions involving the metabolism of carbon chains of glucose, fatty acids, and amino acids. This occurs in the presence of oxygen. Okay. With that, when food is ingested, large macromolecules are then broken down into simple molecules. With this, proteins are now broken down into amino acids. Carbohydrates are broken down into simple sugars like glucose. Fats are broken down into both glycerol and fatty acids. Glycerol and amino acids are broken down into the pyruvic acids. Okay, this is how the breakdown actually works. After glycolysis and the Krebs cycle have occurred, a total of 4 molecules of adenosine triphosphate have now been produced. Okay. When the oxygen is absent, respirations can still occur via an anaerobic process. But then, because of that, lactic acidosis can then develop with shock due to insufficient O2. So how important is it to oxygenate your patients? We should be saying, yeah, exactly. Big importance, big importance. Very important to oxygenate your patients, right? Now you have something called the electron transport chain. There are 34 molecules of ATP that are produced in an aerobic process. Overall process is termed anaerobic respiration. So for cellular respiration, glucose and oxygen are required. Nearly 1/2 of the energy is recaptured as high energy electrons, which are stored in the cells through synthesis of ATP. The end result is 38 molecules of ATP. As the end result, we have 34 that are produced through anaerobic process. We end up gaining 4 more with that. All right. All right. So let's see here. Do I want to take a break now? All right. Why don't we take 10 minutes and we'll come back, because I'm going to start getting into diffusion, osmosis, filtration, all that kind of stuff here. So let's take 10 minutes. We'll come back at 7:10 and we'll continue on. I don't want to overload you guys too much.
This conference will now be recorded.
All right, and we're back. All right, so cellular transport mechanisms. We're going to talk about osmosis, diffusion, things like that. So cellular transport mechanisms refer to how a material enters and exits the cell. And we kind of covered a lot of this already with the gases while we're giving oxygen and things like that, how it diffuses in the alveoli at the cellular level to the alveoli to expel and bring back in stuff for oxygen transport, and then dumping stuff off using the cells to move through the system, utilizing hemoglobin and red blood cells and things like that, right? It's the same thing with fluids moving through the spaces to help I'm trying to think of the word I'm trying to use, to basically help maintain that homeostasis. So electrolytes are chemicals that are dissolved in the blood and are made up of, made up of a salt and or acid substances. This allows differences in concentration between intra and extracellular environments. So the difference in concentration of a substance on either side of the cell membrane is called the concentration gradient. And we're going to talk about how things move from one to the next. The cell membrane determines whether materials are allowed to pass through. Will it allow that chemical and or gas, the chemical, to pass through that gradient that's there? So as you can see here, the passive movement of a solute moving from an area of higher concentration to an area of lower concentration until an even distribution of particles is achieved is called diffusion. As you can see here, you have the lipid molecule, soluble molecules moving through. This is called simple diffusion from area of greater concentration over here, moving through the cellular membrane, moving through to the inside where it has lesser concentration to maintain or meet that homeostasis, or the particles moving to distribution so they are both the same on both sides. This allows us to move that gas. And the gas that we're moving, a lot of it would be the carbon dioxide being one of the biggest ones that we move from one to the next. And then obviously oxygen going from outside to in, carbon dioxide from inside back to out to expel the gas. Another method of moving substances is called filtration. So the kidneys filter compounds from the blood. We're going to cover more in detail during renal emergencies and how this stuff actually works. And there are medications that actually inhibit a lot of this kind of stuff, but nothing that would be given at the AEMT level. But you may come in contact with this to help push and filtrate and move fluids when patients are on home medications. So kidneys filter compounds from the blood. So it comes in, they filterize, and we'll do the breakdown of the kidney later on, and how that pushes back out into urination, moving through the bladder and whatnot. Wastes are removed from the blood and excreted, like I said, through the urine. Facilitated diffusion is a carrier molecule that moves substances in or out of the cells from areas of higher concentration to areas of lower concentration. So energy in this is not required. The number of molecules transported is directly proportional to the amount of the concentration that is there. This is an active transport, which then is the movement of a substance against a concentration or the gradient. So endocytosis or exocytosis are processes that use energy from the cell to move substances in or out of the cell without crossing that cell membrane. There are three forms of endocytosis, and they are pinocytosis, phagocytosis, and receptor-mediated endocytosis. Those are the three different forms. So the figure that you see here shows facilitated diffusion. So in figure A, or sorry, figure A, first part, particles move from an area of higher concentration towards an area of lower concentration with the assistance of a protein. Okay, as you can see here. The act of transport then uses energy from adenosine triphosphate to open a pathway for compounds to move against the concentration gradient. Okay, as you can see it being opened up and moving against the gradient to move the cell through. This is facilitated diffusion here, but moving through the cell to get into the other side. Okay, so lower to higher and higher to lower, right? So you have them moving through and then reversing back to the other side. In order to have active transport, you need to have adenosine triphosphate to assist with that transport of pulling through the cell. Does that make sense? Everybody good with that? All right.
Yeah.
Perfect. So osmosis is the passive movement of a solvent or a liquid from an area of low solute concentration to one of high concentration through a selective permeable membrane. The membrane is permeable to the solvent, but not the solute. As you can see here with the sodium ions being inside, they're going to be traveling through the membrane. Osmotic pressure, which is measured of the tendency of the water to move by osmosis across a membrane. So it's going to move it through. These are all sodium and potassium. And we'll get over that a little bit later when we talk about cardiology with the sodium potassium pump and how all that stuff works. Oh, a little too far there. So tonicity is the concentration of a solution or its ability to draw or give water. A solution with a higher solute concentration compared with another solute is hypertonic. A solution with a lower solute or concentration is called hypotonic. An isotonic solution is one in which there is an equal concentration of solute and liquid on either side of the membrane. Let's stop there for a second. We have hyper, hypo, and iso, right? What medication do we have as an advanced EMT that is isotonic?
Sodium chloride.
Sodium chloride, normal saline. Exactly. For crenation, if too much water moves out of the cell then shrinks abnormally. Lysis, if too much water enters the cell, then it will swell and burst.
We can
So-
cause that with a too high amount of saline, though, correct?
Say that one more time, George. Sorry.
I said we can actually cause a hypertonic situation if we give too much saline, though, right?
Right. That's why we don't want to flood patients. So here are some numbers for you. Okay. These are good numbers that you should memorize when you're giving fluids. Other than looking at patients that are septic, okay, where we give a lot of fluid. If you have an adult, what you should be looking for is a 30 mLs per kilogram administration of fluid. 30 milliliters per kilo. Right? If you guys have paper and pen, write it down. If not, you can rewatch the lecture again. I'll put it in here too. Adult is 30 ml per kilogram. Okay? Pediatrics are 20 mLs per kilo. This is saline, normal saline, okay? And neonates is 10 mLs per kilo, small amounts of fluid. So if you have a neonate or a pediatric, and in the pediatric, let's say they weigh 6 kilos, right? And they're neonates, so newborn to 30 days old, you're going to give 60 mLs of fluid, and that's all you need to give them. All right. Now take this and talk about metric system math, right? Kilograms. I'm going to give you guys a quick, easy, down and dirty way to convert. Because you guys, I know this is not this topic of discussion, but you need to know this. All right. And this kind of breaks down into osmosis and how we're moving fluids too. A lot of things we do in the pediatric, everything we do in the pediatric world is going to be considered weight-based. what you do is you divide the total pounds, divide by 2 and take off 10%, and that gives you your kilograms. So if I said a patient weighed 200 pounds, divided by 2 is 100. And if it's a 3-digit number, you take the first 2 digits of that 3-digit number and subtract that from that number that's there. So 200 pounds divided by 2 is 100, minus 10 is 90. That's how many kilograms it is, 90 kilos. That's easy math conversion. If you have a calculator, 200 divided by 2.2. If you don't have a calculator with you, divide by 2, take off 10%. If the patient weighs 50 pounds, divide by 2 is 25. Take the first number, subtract 2 is 23 kilos. Does that make sense?
Yes.
Right? Simple. Let's keep it simple. Simple math, right? For now. So we talked about giving fluid, right? So we're administering fluid to help with osmosis, to help move things through the permeable membrane, to help, in turn, maintain balance, right? Oh, too far. Fluid balance maintains homeostasis. Intracellular, ICF, intracellular fluid within cells, within individual cells, right? So I'm going to get to this here. There's another point behind this with administering fluid. But the body fluid is divided into 2 main compartments, intracellular and extracellular fluid. Intracellular ICF exists when individual cells and equal approximately 40 to 45% of total body weight. You will see those numbers again. Intracellular fluid equals approximately 40 to 45% of total body weight. Extracellular fluid exits outside of the cell membranes and equals approximately 15 to 20% of total body weight. So ECF is divided into intravascular fluid and interstitial fluid. Intravascular fluid, plasma, is found within the blood vessels and accounts for approximately 4.5% of total body weight. Interstitial fluid is located in the spaces between the body's cells and accounts for approximately 10.5% of total body weight. If fluid is lost from anywhere in the body, it distributes the balance among various fluid compartments, right? If it's lost, fluid balance maintains homeostasis through equal intake and output of fluids. Major mechanisms for fluid homeostasis are listed in table 7.2 as well. So the sensation of thirst occurs when the body fluids become decreased. You become thirsty, you need to drink. The body can maintain fluid balance by shifting water from one compartment to another. What happens if we lose fluid too much? What is that called?
Dehydration?
Dehydration. Also, what type of shock is it?
Hypovolemic.
Hypovolemic shock. They become hypovolemic. Patients that become hypovolemic have a lack of fluid because we're shifting from one to another for our body to maintain homeostasis, which then would put them in what type of shock? I know hypovolemic, which stage? Stage 1, and or we also call compensated shock, right? Our body is trying to compensate to meet homeostasis by moving fluid that's heavy in one to fluid that's light in another in the compartment to meet that. Okay, but in turn, we're losing fluid. What else is happening in the body? Vascular and everything. We're losing body fluid, right? If we're losing fluid, whether it be through, let's say, blood loss, excessive diarrhea, excessive vomiting, we're losing that fluid that we have inside, right? What's going on? Do we have enough cells to be able to maintain homeostasis?
No.
No, right? Because we're losing our fluid. We're losing everything, right? We're becoming compensated. We're compensating, right? So what are we going to see in compensated shock?
Low blood pressure.
Rapid pulse.
Increased
Rapid pulse.
tachycardia.
So increased respiration, tachypnea, tachycardia, rapid pulse. Why is that happening?
Because the body's working harder to maintain the homeostasis.
It is.
Um,
By increasing respiratory rate, what does that do to the oxygen?
so it increases the oxygen input.
Because your body has an increased oxygen demand because it's not transporting appropriately, right? So we've then expelled most of that out. So we're trying to breathe faster to bring more oxygen in. Our heart rate increases to do what?
Increases to
Gives
to
more
keep up with
oxygen.
demand, but also more oxygen, more blood to through the body.
Excuse me. Correct. So now we're trying to oxygenate our system. The heart is pumping faster to move red blood cells around faster to meet that demand because of the fluid loss, right? And we need to fix this. Now we're going to see hypotension. We start getting into decompensated shock. We'll see bradycardia. Our respiratory rates are going to start normalizing and becoming decreased to the point where it becomes irreversible and the patient dies, right? We want to catch that in compensated shock. We want to pick up on those signs and symptoms for the fluid loss. Let's look at this now, okay? Increased blood, or increased blood sodium concentration, right? Osmoreceptors in the hypothalamus then causes the pituitary gland moving down to ADH, goes in the bloodstream, into the kidneys, right? Increases water reabsorption, goes back around. This is what we want to happen. This is good balance. If we have an imbalance somewhere and we have to start maintaining, we start losing different parts of it, right? Now we put this into perspective. Patients that have excessive vomiting, excessive diarrhea causes them to have an electrolyte imbalance, right? Causing the lack of potassium, lack of sodium, magnesium, okay? And we start seeing the potential for T-wave issues, but we're going to see more of an arrhythmia. Now our heart can't pump effectively because we're not getting the correct electrolytes. By doing so, we need to replenish. Now we give them fluids. We base it on 30 mLs per kilo so we don't make them hypertonic, right? And we get our kidneys working appropriately. Patients, LR is also a great one to utilize, Mike, exactly, right? And LR is still within the scope of practice for AEMTs. So now we start doing that. We start increasing our electrolytes, increasing our fluid to make better homeostasis. When a patient's in compensated shock, going into decompensated shock, what else is going to shut down? I'm circling it with my mouse. What is that right there? I'd highlight it, but I'm not sure if I could.
Vascular system.
The
Plasma?
kidneys. The kidneys start to shut down. If the kidneys shut down, what can you no longer make? Urine, right? If you can't make urine, what happens to your renal system?
It'll start to shut down.
Right, an acute renal failure. And then what has to happen to that patient?
Dialysis.
Dialysis. See, now we're onto something. You guys are all thinking this is great, right? And a lot of this can be fixed if we can pick it up in the field quickly, looking at our vital signs to prevent acute kidney failure, renal failure, make sure they're getting enough fluid based on 30 mLs per kilo, and we start treating our patients to prevent the system from failing. Now, here's another number for you guys to remember. The average adult puts out 30 mLs of urine per hour. 30 mLs of urine an hour. That's the average, okay? Now, this is a patient who has a Foley catheter in place to measure. They should be putting out 30 mLs an hour. If they're not, and they're overproducing, right? Why? Why do we have that happen? Were they given a diuretic to help with that, to help maintain that fluid balance because they have too much fluid buildup, right? So how would we find too much fluid? We talked about patients that have a buildup of interstitial fluid. When will we see that?
Pitting edema?
Edema, you got edema right, but what would cause the edema? Right? We have congestive heart failure, right? That Mike was just mentioning. So that would be CHF would be more towards, you're right, heart failure.
Hey, get back here.
What side of the heart? What specifically? What side of the heart is causing failure for that pitting edema?
It's the left side, isn't it?
Nope, not the left.
Oh.
The
Right side.
right side is failure, right? So if the heart cannot pump fluid, if you have right-sided failure, it's no longer going to be able to pump in and pull back in through the right atrium to the right ventricle to put into the lungs, right?
Right.
Therefore, we're going to start having right-sided failure and pitting edema.
Hey,
Pitting edema goes back to the whole interstitial spacing, and we start getting interstitial fluid. To remove that fluid out of those areas, they need to get something called a diuretic. The diuretic that we administer, or they take on a daily basis, whether it be Lasix, furosemide, hydrochlorothiazide, all these different medications that serve as diuretics have something in common. They're called loop diuretics that help stimulate the ascending and descending loop of the kidney, which then also in turn is a non-potassium sparing diuretic. And if you miss out all your potassium, what's going to happen? Keep going back to the T waves. Yep. You piss it out and you become hypokalemic.
come on.
Then we start seeing increased cramping. We start potentially seeing T wave, flattened T waves. And you're also going to start having cardiac arrhythmias. We just want an entire spiel about homeostasis and just a little bit of fluid issues. All these things can happen. That's why it's so important to obtain a very good history in medications, because everything plays a part in our fluid balance of what we're taking. For meds they're on, medical history, and everything, right? So we take all this stuff that we learn, and then we're going to figure out how to treat it. Just because they have CHF, that's great, but what's going on internally? If they have pulmonary edema, we know we have left-sided failure because the heart can no longer, left ventricle no longer pump that fluid out, causing filling of a fluid, acute pulmonary edema. That's treated a little bit differently, right? We're going to have piss poor gas exchange. We're going to have drowning, internal drowning in the lungs, and we got to get rid of that. We got to push the fluid out, and we have medications that fix that, like nitrates and CPAP and all that other kind of stuff. But going down to the cellular level, we got to make sure that all this stuff is working appropriately. And if we have an imbalance, fluid balance maintains homeostasis through equal intake and output of fluids. If there's a deviation somewhere, that's when we start having different signs and symptoms. Does that make better sense now? Did I lose anybody on that? Or does that make more sense that I brought it into perspective with a patient care? Cool. Cool, cool. I like it. All right. So there are 12 major organ systems. An organ system is composed of at least two kinds of tissue that are organized to perform a complex task. Here are the 12 that we have. Integumentary, skin, skeletal, muscular, nervous, endocrine, circulatory, lymphatic, immune, respiratory, digestive, urinary, and reproductive. The skeletal system gives us our recognizable human form and protects our vital internal organs. Remember that bones constitute the major structure of the skeletal system. Cartilage, tendons, and ligaments are important connective tissues, right? Supportive structures in the skeletal system are listed on table 7.3, which you guys will be able to see that within your book. or on your ebook. Remember that a tendon connects muscle to bone, and a ligament connects bones to each other. It's a bone to bone. So when you have a sprain occurs when the bone ends partially or temporarily dislocate, and the surrounding or the supporting ligaments are then stretched or torn. A strain is a muscle pull occurs when a muscle is stretched or torn. The cartilage also provides cushion between the bones. Right? So we're going to do our assessment, and we'll talk more about assessment and skeletal assessments, things like that. We talk about stuff on that first in-person day. So a lot of this stuff's going to be review, okay? Also, some of this stuff's also very important when we start doing different procedures. So classified according to their shape as long bones, short bones, or flat bones. Right? Long bones would be like the femur, tibia, fibula, ulna, radius, humerus. Short bones would be the bones of the wrist and the ankle. Flat bones are certain skull bones, ribs, sternum, scapula. Irregular bones have unique shapes and are designed to perform specific functions, including the mandible, many facial bones, and those that comprise the vertebrae and the spinal pelvis. What is the only bone in the body that is not connected to another bone somehow? Perfect. And where is that located? Matt said the hyoid bone. Yeah, kind of in the throat, in that area, or like underneath the tongue. All right, so bones consist of a shaft. Ends and growth or epithelial or plate. Trying to read this. I can show you guys something here in a second too. Yeah, this is not a good picture to show. Should be one coming up here that I can show you guys. All right. So the periosteum consists of a double layer of connective tissue in the lines of the outer surface of the bone and the endosteum lines of the inner surface. The diaphysis of the bone of many bones include the medullary cavity and the internal cavity that contains bone marrow. There are two main types of bones that are compact bones and then cancellous bones. The compact bone is mostly solid in a few spaces. The cancellous bone consists of a lacy network of bony rods called trabeculae. So I'm going to show you guys, I'm trying to see if I can find it on here. Can you guys see the mouse moving on the screen? I do this.
Yes.
Sweet. All right. So, here we go. So we look at the long bone here. We have the diaphysis, which is the long, straight part of the bone here, right? I'm not sure if it's going to get into detail, but where you see the bone come in, okay, so let's say it's down by the epiphysis down here, moving into metastasis down here, moving up the diaphysis, going up into this area right here, okay? If we're doing something with interosseous, like IO, which is within the advanced EMT scope of practice, we're going to be following the tibial plateau, tibial tuberosity, which is here. We're going to slide our fingers medial. So if everybody were to grab their leg right now and kind of slide right up the tibia, okay, all the way up just to the just below the kneecap, and you slide your two fingers in medial, you'll find something called the tibial plateau. The tibial plateau is the location of one of the 6 locations on the body that we can use an IO drill, right? What's going to happen is it's going to drill into the spongy part here that you see, a spongy bone, into where the bone marrow is located. into the cavity. As we drill in, there's going to be increased pain, but only the pain only increases anytime you put some kind of fluid into it, right? Which is why you guys have lidocaine to numb the site as the administration goes before you start giving fluids. So that's where an IO would go into, would be right in this location here. Right? Joints, whenever two long bones come in contact, a joint articulation is then formed. A joint consists of the ends of the bones that make up the joint and the surrounding connecting and supporting tissues. As you can see here. Right, the joint space is located here. This is the meniscus, located here. Articular cartilages, located there. Synovium is located here with some synovial fluid as a cushion. Patella being the kneecap, which is connected here. Right? Femur comes in, tibia comes in here. Right? This is where bone to bone comes together with our connecting ligaments, holding things together. Right? Now we start talking about our tendons. Okay, we have ligaments connecting bone to bone. Then we have our tendons that connect muscle to the bone located in here. Okay. So remember, we have our quadricep down here, patellar tendon located here as well. When you guys come in on that Sunday, I'm going to show you guys how to do different tendon and ligament assessments as well. I'll show you guys how to do different ones to check patellar, meniscus, things like that. I'll show you guys how to do all those. So some joints have a slight limited motion in which the bone ends are held together by fibrinous tissue called symphysis as well. So these joints in the knee are called hinge joints because it runs off a hinge moving back and forth, as you can see here. So bone ends of a joint are held together by a joint capsule. We have hinge joints, ball and socket joints. So where would we find a ball and socket joint?
Shoulder.
Hip. Shoulders, and what's the other one in the hip? Break it down a little more than just a hip. So the elbow would be a hinge joint. And I'll show you guys in the next slide too. I'll point it out even better. So on the inner lining of the joint capsule is the synovial membrane where the synovial fluid is located. It kind of helps lubricate the joints as you move. This produces a thick which is a thick lubricant. The shoulder joint is a ball and socket. Finger joints, elbows, and knees are hinge joints. Okay. There's another ball and socket as well, which I'll show you guys where that is located in the next slide. Where would I find a saddle joint? You only have two saddle joints in the entire body. Where would I find them?
The thumb.
The thumb, exactly. Yep. All right, so if you follow my mouse, looking at the upper extremity, lower extremity, shoulder girdle, pelvis in here, symphysis pubis located down here, where the femur comes up into the femoral head that connects into the hip, the pelvis. That is also a ball and socket located here. And very, very common area where you'll find fractures with elderly that fall on the ground. Everybody's like, oh, it's a pelvic fracture. 90% of the time, it's going to be a femoral head fracture located here. And to repair that, a lot of times they just drill in and they put a screw through it and hold it together. Very simple procedure that they would utilize. So the skeletal system is divided into the axial skeleton and the appendicular skeleton. The axial skeleton is composed of the skull, thoracic cage, and vertebral column up in here, right? The appendicular skeleton is composed of the arms and legs and their connection points and the pelvis, right? So axial, appendicular. The heart and lungs and the great vessels are enclosed in the thorax, which is in the thoracic cavity. How many bones are there in the body? (206). So the skull consists of 28 bones in 3 anatomic groups: the auditory ossicles, the cranium, and the face. There are 6 auditory ossicles functioning in hearing. The remaining 22 bones comprise the cranium and the face, and the mastoid process is a cone-shaped section of the bone. All right, we need to memorize the ones that are on the screen because you will be tested on these again. The cranium serves the entire skull, right? We have frontal and parietal bones. And also remember that those are also in the brain where the lobes are located: frontal, parietal, temporal, occipital. Occipital bone protects the occipital lobe. Temporal bone protects the temporal lobe. The parietal lobe is protected by the parietal bone. Frontal lobe is frontal bone, right? So now I just taught you lobes of the brain along with the ones that protect it. And they're all held together by sutures. And we'll cover that here in a second. In the face, we have what they call the eye socket or the orbit, which, by the way, is a very, very common fracture area for falls on the face. And what would you see signs of an orbital fracture? What would you see? What would that be called? What is the name of the sign that you would see for orbital fractures? Yep, raccoon eyes. Right? In the face, we also have the nasal bone, right? Protected by nasal cartilage. The zygoma or zygomatic bone, which is the cheekbone, the maxilla, and the mandible. On the back side, we have the external auditory medius, the mastoid process, the temporomandibular joint, and the cervical vertebrae located here. How many? Matt just shared you guys an anatomy atlas, which is pretty cool to utilize. It's on the group if you guys want to look at it. So with that being, thanks, Matt. For that being said, how many cervical vertebrae do we have? How many cervical vertebrae do we have?
7. C1 to C7, right?
Right, exactly. What is another name for C1? What is the technical name for it? There's only 2 of them that have different names other than just C1 and C2. You guys remember that one at all? Yep. Matt said the atlas. Think of it as the globe, the atlas sitting on top. What is C2 called? The axis, exactly. So the atlas has to sit on the axis. Then C3 through C7, T1 through T12, lumbar, there are 5, and then 4 for the coccyx, right? Those are all just L1, T1, T2, S1, all that. Those don't change. All right, so the cranial vault consists of 8 bones that encase and protect the brain. Right? We have the parietal, temporal, frontal, occipital, sphenoid, and ethmoid bones. Right? So as you can see, the different bones that are here. Now, with that being said, right, we have fontanelles that are located here and here, right? And we have different sutures that hold it together, right? We have the coronal sutures, which are located here. Sagittal runs here, right? The lambdoid suture runs back here, okay? So we have 3 different suture names we got to memorize. Fontanelles, right? On an infant, are fontanelles a assessment tool? I should say. Yes. If I said that the fontanelle, okay, remember, do not ever push on one very hard. If I said the fontanelle on an infant was sunken in, what would that be? What would that mean? Yep. Dehydration, exactly. Dehydrated. What if the fontanelle is bulging out?
Intracranial pressure.
Exactly. ICP. Increase intracranial pressure. So the brain and the spinal cord are then connected through a large opening at the base of the skull. What is that base of the skull called? Another name for the base of the skull. What is that big, large opening? Right, Matt got the foramen magnum. Yep. So the bones of the skull are connected at a special joint known as sutures, which we just talked about. Now, as we're growing up, so infancy, okay, going like neonates, infants, pediatrics, right? These sutures are not fully connected yet. They're kind of they're there, but they have to be free enough to allow the head and the bones to grow and expand, right? And once they mature enough to being an adult, we stop growing, then those sutures then become hardened. Okay, they have to have room for expansion as they grow. All right, as you can see, the foramen magnum located here. So this is the floor of the cranial vault, which is divided into 3 components called the anterior fossa, middle fossa, and posterior fossa. Anterior being up front, posterior being up back, middle being middle, right? So the crista galli forms a prominent bony ridge in the center of the anterior fossa. Okay. On either side of the crista galli is the cribriform plate of the ethmoid bone. The olfactory nerve sends projections through the foramina in this cribriform plate into the nasal cavity. Now we'll talk about the different nerves later on, but there are 12 cranial nerves you need to understand. Right? There are 14 facial bones that form the structure of the face. The frontal and ethmoid bones are part of both the cranial vault and the face itself. These 14 bones include the maxilla, mandible, zygoma or zygomatic, palatine, nasal, lacrimal, vomer, and inferior nasal concha bones. Kind of off topic, why is it important to understand where the lacrimal bone is located?
Is it your sinus cavity?
I just put it out in the text. What is sludge?
Oh,
You remember that one there? It's just kind of about, right, tears, right? Exactly. So part of a patient that has organophosphate poisoning will have increased production of tears coming from what they call lacrimation, right? Lacrimation, which is part of the sludge acronym utilized to tell if a person has organophosphate poisoning. So it's good to know where that one there is located. If you see lacrimation from the criminal bone located in that area, there will be increased tears. So yes. The facial bones protect the face, eyes, nose, and the tongue as well. So as you're palpating, okay, and you're doing your documentation, we start talking about head, ears, eyes, nose, and throat. Now, this is where we have to become more in depth in our documentation. Not just palpated the head, ears, eyes, nose, and throat. We found some swelling above the eye. Right? Was there swelling around the orbits causing raccoon eyes? Was there what would they be called if you had bruising behind the ears? What is that called? Because we're talking about facial bones.
Isn't
Bruising,
it battle scars?
battle sign. Yep, battle sign, which would indicate what fracture of a bone. What bone fracture? What part of the skull? More particular. Yep, exactly, Mike. Basilar skull fracture. Now, if you had a patient that has battle signs with a basilar skull fracture, what is contraindicated for a patient who is unconscious? An NPA, exactly. So we can't put in nasopharyngeal airways for these. This is why it's so important when you rush in and see an unconscious patient from a fall that before you start placing airways in place, you do an assessment. Take a look. All right. So bones of the orbit. They're a cone-shaped fossa that encloses and protects each eye. They contain blood vessels, nerves, and fat. A blow to the eye may result in a fracture of the floor of the orbit or a blowout fracture, which can cause leakage of blood and fat into the maxillary sinus. All right. Very, very common fracture, which we talked about. The bones of the nose, where the nasal cavity comprises portions of several of the facial bones. The nasal septum, and its separation between the nostrils and is located in the midline, as you can see here. This contains cavities known as the paranasal sinuses. And if you have a patient that's inflammation, this is called sinusitis of the paranasal sinuses. It's called sinusitis with inflammation. The mandible and temporomandibular joint. The mandible is a large movable bone comprising the lower jaw, comprising the lower jaw, and containing lower teeth. The posterior condyle of the mandible articulates with the temporal bone and the temporomandibular joint, which would be TMJ, allowing movement of the mandible. The hyoid bone floats in the superior aspect of the neck, which then supports the tongue. So I'll show you guys in the next slide here. All right. So we talk about the neck, supported in the cervical spine. The upper part of the esophagus and trachea lie in the midline of the neck. All right. So you have your thyroid cartilage located here, your cricoid cartilage located below, and that little indent inside there is a cricothyroid membrane. And that's an important landmark for medics, so that's where they do crikes. That little spot right there where we have to cut holes or put needles inside, right? The muscle that connects down through here to your sternum, going through here, is called the sternocleidomastoid muscle, right? So it starts up top, goes down through on both sides. Your trachea being located here. What is the difference between a pediatric and an adult trachea?
Pediatric is smaller.
Okay, I'll give you that. It's smaller, but what else is different about it? Yep, cartilage is not fully developed. So within our trachea, we have cartilaginous rings, okay? In an adult, right, we're more solid. The cartilaginous rings in an adult have now fully developed, versus a pediatric where they're more pliable, right? Which is why it's so important to make sure you pad underneath the shoulders to maintain an open airway. It's very easily occluded just by the bending of the neck with hyperflexion or hyperextension can cause the trachea to almost fully occlude based on the pliability of the trachea. The spinal column, cervical, thoracic, lumbar, sacrum, coccyx, right? We have C1 through C7, the first vertebra. Then we have T1 through T12. Then the lumbar, sacrum, and lumbar, we have 5 vertebrae. What's different about the sacrum and coccyx?
The coccyx aren't attached.
And the sacrum is fused together. Yeah. A lot of this stuff here is a lot of its review. So the first cervical vertebra, C1, is called the atlas. The atlas articulates with the occipital condyles at the base of the skull and at the atlanto-occipital joints. Oh boy. All right, I hear you, Kenny. I saw your message. The second cervical vertebra, C2, is known as the axis, as the point which the head rotates from side to side. The spinal cord is an extension of the brain, which then contained within the protected by the vertebrae of the spinal column, as you can see here. The interior part of each vertebrae consists of a round, solid block of bone called the body. The vertebrae are connected by ligaments, and between each vertebrae is a cushion called the intervertebral disc. When we do an assessment and we're palpating the spine, it's not just feeling that they're there. We need to look for something called step-offs. Okay, as we're palpating down, we're trying to feel these bony arch called the spinous process, right, to see if it's broken off inside or if there's any kind of step-offs or moving off to the side. Okay, so we're looking for spinous process and step-offs of the spinal of each vertebrae. So taking your fingers and rubbing them down the spine really fast is not a detailed assessment. It's starting with C3, where you're going to start being able to feel C3 down and palpating each vertebrae going down, all the vertebrae down to the coccyx. So yeah, you're going to have to go right down into the patient's crack and start palpating down to the very bottom, okay? The breakdown of the actual vertebrae is pictured here on the right-hand side. We have the bony arch. Then we have the spinous process, which we're palpating, and we're also going to be able to feel the transverse process on both sides. Going down, we have the lamina and the pedicle. As you can see now, it's protected. The spinal cord is now being protected by the pedicle looking here, and then the body being out back. The spinal cord is protected in the middle, right? As you can see, the spinal nerve roots run through. I wish I had a better picture, but you can kind of see them. No, it's not a great picture at all over there. Which is why it's so important to make sure we're protecting this and placing cervical collars and everything else on these patients that are injured. The thorax is formed by 12 thoracic vertebrae and pairs of ribs. Vertebrae being up back, and they come around, hooking into the sternum. Then we do have some floating ribs down below. So these are formed by 12 thoracic vertebrae and the 12 pairs of ribs. The boundaries of the thorax are the rib cage anteriorly, superiorly, and posteriorly, and the diaphragm inferiorly. And interior midline of the chest is the sternum. The sternum is broken down into 3 different sections, right? We have the sternal notch. We have the main part of the body here. The mambrium is located up top. And then we have the sternum. We have distal, medial, and proximal part of the sternum. Then we have the xiphoid process down below. This little bony extension down towards the end, right? intercostal, doing on the muscles too much here, but the thoracic here, we have rib 1, 2, 3, and 4, working our way down to 12, and then we have floating ribs located down below for 13 and 14. Why are counting ribs important? Oh, I didn't go that far. I apologize. There we go.
Placement of the 12 lead.
Placement of 12 lead. Because what we're looking for is the intercostal space between. Okay? So we count down to the fourth intercostal space, right and left of the sternum, is where we place V1 and V2 leads. Right? Then we look at mid-clavicular line and mid-axillary line for 12 lead placement. Also, palpating the ribs is also going to help us find if we have fractured ribs or not. Right? So as we're going down, we do a quick assessment, rapid trauma. We take our hands, we place them over underneath the breasts of a female or the pecs of a male, spread our fingers nice and wide, have take a deep breath in and out, and we're looking for good rise and fall. If there's a deviation or we feel something different, it potentially could be a fracture, right? What is it called when we have 2 or more fractures in a row? Yep, flail section or flail segment. That's something to be noted. And in turn, broken ribs are very, very sharp, and they can also cause a puncture of the lung, causing a pneumothorax. The upper section of the sternum is called the membrane. The body comprises of the rest of the sternum except for a narrow cartilage tip inferiorly, which is called the xiphoid process. That was a very important landmark many, many years ago, about 20 years ago or so, was a landmark for using CPR. Obviously now that's different. Now it's just lower half of the breastbone. The largest structure within the thoracic cage are the heart, lungs, and the great vessels that keep our body alive. That's why it's protected. Just beneath the membrane of the sternum, the arch of the aorta and the pulmonary artery exit the heart. So you can see the sternum does a lot of protection here, right? The esophagus lies behind the great vessels and is directly on the anterior aspect of the spinal column. So all space within the chest that is not occupied by the heart, great vessels, and esophagus are occupied by the lungs, which is located all through here in the diaphragm, right? So to kind of go a little more in, because you guys like the fact that I brought up certain things like this. A patient who is in cardiac arrest and CPR is being done, you have a brand new EMT that is ventilating a patient 100 times a minute, right? What is going to happen to that stomach?
It's gonna blow up like a balloon.
Oh, like a balloon. Exactly. What we call gastric distension, right? What happens when you get gastric distension? Other than vomiting. Okay, you got pressure, right? Pressure pressed against what? The diaphragm, right? Causing increased pressure on the heart and the lungs, which then makes your CPR ineffective. Which is why it's very important to ventilate a patient appropriately. Because the more pressure on the diaphragm makes it less able for the heart to function appropriately. All right, the appendicular skeleton includes bones of the shoulder and the pelvic girdle and the upper extremities and the lower extremities as well. The shoulder girdle attaches to the upper extremity to the body at the glenohumeral joint. The 2 major components of the shoulder girdle are the scapula and the clavicle. The clavicle, being located here, is under a lot of tension and pressure, which is a very, very common fractured bone, especially in sport injuries, right? The scapula, a lot stronger of a bone. I've seen more scapular fractures in motorcycle accidents than any other kind of injury that I've seen. Right? The humerus runs here. The acromion process is located here, right? And they're trying to see if they can find. So we have the acetabulum located here. This is a landmark in the shoulder for doing interosseous administration, right? So it's located here. We'll cover more of that when you talk about IOs and you guys start drilling bones in class. Right. The two major components, scapula and clavicle, raised up on the scapula is called the acromion process, which is located here. Another very commonly fractured bone through the acromioclavicular or AC joint. A ball and socket joint into which the head of the humerus articulates with the glenoid fossa, which is part of the scapula, as you can see going in here. A bursa is a pad-like sac situated between the tendon and a bone that cushions and protects the joints. The upper extremity consists of the arms, the forearm, wrist, hands, and fingers, and the humerus is the bone of the upper arm. Right? Humerus comes into the elbow. We have the radia and ulna underneath, the medial condyle, Euclidean process, as you can see looking down through. Looking at the biceps, triceps, ulnar radius, radial styloid is located down here. Ulnar styloid is located over here. All right, let's go into the hand. So the forearm and the wrist extends from the elbow to the wrist, which contains bones of the radius and ulna, coming into the wrist here. In the wrist, we have 8 different bones. 8 bones in the wrist. There are 7 in the ankle. As we go down, we have what they call the metacarpals, and these are actually labeled metacarpal 1, 2, 3, 4, and 5, which then go into the phalanges, and the phalanges actually breaks down into medial and distal phalange, proximal and distal phalange of the thumb, proximal, medial, distal of the fingers. Fingers have 3 different bones, thumb has 2. The saddle joint sits right around here as they go together. With the pelvic girdle, where the lower extremity attaches to the body, as you can see, you have major aortas and inferior vena cava. You have the major ascending, descending aorta. This contains a ring of bones formed by the sacrum and the coxal bones. Each coxa consists of 3 fused bones of the ilium, ischium, and the pubis. So the iliac crest, ilium is a big part of the bone here. The sacrum is located here, right? The pubic bone or pubis is here. The symphysis pubis is what is located here, which connects the 2 together. Now, have you guys ever heard of an open book fracture before?
Yep.
Okay, no, yes. So this is the book. Okay, when they talk about open book fracture, this is split apart into 2. If this splits apart, what is at risk at this point?
Internal bleeding, right?
Severe internal bleeding, major arteries, femoral veins running through here. If you open book fracture and you sever a femoral artery, how much blood can your pelvic cavity hold on average?
It's like 3 or 4 liters. 3 or 4 liters. Something
Yeah,
like that.
exactly. So you have 3,000 mLs, 3 liters of blood that can hold in your pelvic cavity. An adult carries how many liters of blood on a normal basis? How much blood?
5.
Yeah, between 5 and 6 liters. So half your blood supply can bleed out if the pelvis is not stabilized appropriately. If you have an open book fracture, you have a higher chance of having a type of arterial type bleed in the pelvis. And there's nothing that we can do about it in the field. You can't tourniquet it. You can't do anything. It's there, right? Which is why it's so important that we stabilize that pelvis as soon as possible before moving them, right? So on that note, we've got another hour. Let's take 10 minutes or so. Let's say take 10 minutes, come back at 8:33, and we'll continue on. We're about halfway through.
This conference will now be recorded.
All right, so the lower extremity, it breaks it down into the hip, the knee, the thigh, leg, ankle, foot, and toes. The acetabulum is the socket, the ball and socket joint that connects the pelvic girdle with the lower extremity. Okay, as you can see on here. The femur is the longest and strongest bone in the body. The uppermost portion of the femur, the femoral head, articulates to the pelvic girdle and the acetabulum. So like I mentioned before, this is the most common fracture that we see, especially in the elderly with a fall. So actually putting on a splint with those would actually hurt and do more damage than it would for a pelvic fracture. These are not ones that you do any kind of traction splint. Traction splints are only for mid-shaft only. Anything in proximal or distal would be more of just a regular splint. So you got to actually palpate and feel to where that femur fracture actually is located. The uppermost portion of the femur, we talked about that one there. In addition to the femoral head, proximal femur consists of the neck, the greater trochanter, and the lesser trochanter as well, which is located here and here. The articular capsule is supported by 3 ligaments that are quite strong, holding things together. Again, like I said, the femur is the strongest bone in the body. Looking at the leg, the distal end of the femur, the leg, the lateral and medial condyles articulate with the proximal tibia at the knee. So as you can see, coming down to the femur, you get the patella located here, then we connect into the tib and the tibia and the fibula out back. The leg is made up of the tib-fib. The tibia is the longer and thicker of the 2 bones, also located in the front, right? So think of the T's for toes, toes in the front, tibia. The medial malleolus lies at the distal end of the tibia. So distal end down here, medial malleolus is located down here. And the fibula runs behind and beside the tibia. An enlargement of the distal end of the fibula forms the lateral wall of the ankle joint and the lateral malleolus. A little bit more about the knee. We talked about ligaments and tendons. Traditionally classified as a hinge joint, the anterior cruciate ligament prevents abnormal anterior movement, hyperextension of the tibia, and there are several tendons as well as collateral ligaments that lend additional strength to the knee joint. As you can see on this sorry about that. As you can see on the photo here. With the ankle, the talus articulates with the tibia and the fibula to form the ankle. The fibrous capsule surrounds the ankle joint, and there are the metatarsals, the phalanges, and the foot are arranged similar to the bones of the hand. The difference is that in the ankle itself, there are only 7 bones located in the ankle versus the wrist that has 8. You have the Achilles tendon that runs back here. This is your medial malleolus, which goes into the ankle itself. Calcaneus down here. The same thing as the metacarpals and carpals. You have the talus, the navicular, and the medial cuneiform. Then we start getting our metatarsals and tarsals, and then our phalanges. It's the same thing. We have the proximal and distal and medial phalanges. So the skeletal system, philosophy behind it, physiology, not philosophy, my goodness. Responsible for several functions. Bones protect internal organs, and with muscles enable movement, right? So we have to have all that as far as the physiology behind it. Various bone cells use calcium to create the structure that is hard and resilient. So if you have a decrease in calcium, is there potential for easier fractured bones? Everybody should be saying yes. Yes, yes. All right. This helps with the creation of various types of blood cells as well, and bones are a living substance with cells requiring blood supply. So if we have a fracture, are they getting blood supply? Everybody should be answering this with depends, right? So I'm going to reply back to you, depends on what? Depends on what?
I mean, it's gonna depend on where the actual fracture is, how bad it is, what caused the fracture. I mean, it's any number of things.
One different variables, right? So with that, though, how are we going to test to make sure we're getting blood supply?
Palpation of the area, vital signs.
Yeah, palpation, vitals, and checking what type of refill?
Cap refill.
Cap refill, exactly. We want to make sure we have good cap refill, and we also check for pulses, right? So if I were to say, where do we check for pulses? Where are they located? What pulses can we check on the body?
Radial, femoral,
Yep.
pedal,
Okay.
brachial,
Brachial,
and carotid.
carotid. What about tibial? Yep. We can check a tibial pulse, which is located by the ankle. And we can also check what they call a popliteal pulse. Where is that one located? Popliteal pulse.
Behind the kneecap?
Behind the kneecap. I was waiting for someone to say the popliteal artery, but yes, behind the knee. So back. Yep, behind the kneecap. You can actually feel the popliteal pulse. So we can check all those different areas, make sure we're actually getting circulation along with checking cap refill. Right? So let's see. Bones protect internal organs. We talked about that already. Helps creation as well because of the collagen and the mineral hydro. I'm trying to pronounce that one today. It's definitely getting late. All right, moving forward. So the musculoskeletal system skeletal component form an upright posture and movement, which are provided by the musculoskeletal system. So bones and voluntary muscles of the body. There are more than 600 muscles in the musculoskeletal system. Muscles outside of the musculoskeletal system include smooth muscle, which are involuntary, and cardiac muscle. So the skeletal muscle includes all the muscles attached to the skeleton. We have straightened muscle or voluntary muscles, which vary greatly in size and shape. We have unused muscles, which tend to atrophy, whereas physical training promotes hypertrophy. Most muscles within the body operate on the principle of antagonistic pairs. The example would be the biceps in the upper arm complete with the triceps. So knowing the different muscles of the body. Some of the big ones you want to know are the quadriceps, medial and lateral quads, okay? Because this is where we're going to be doing intramuscular injections. Another one you want to also know is your deltoids, located on the arms. That's another area where we do intramuscular injections, right? We have the gluteus maximus, where we also can do intramuscular injection as well. So the musculoskeletal system has several functions. One, it has the person's ability to move and manipulate the environment. It's made possible by the contraction, relaxation of this system. Another function of the muscle is to protect the structures underneath them. As far as energy sources go, muscle fibers have just enough adenosine triphosphate for short-term contraction. ATP must be regenerated when fibers are active using existing ATP molecules in the cell. How many ATP molecules are there again? I mentioned it a little while ago. How many ATP molecules do we have at any given time? Anybody remember the answer to that one? I know it's getting late. We're trying to get through this. 34, right? 34, then we create an additional 4 as well, makes a total of 38. All right. As far as oxygen use, oxygen is required for the breakdown of glucose in the mitochondria. So the one hemoglobin molecule reversibly binds with 4 oxygen molecules. The pigment myoglobin is synthesized in the muscles and can combine with oxygen and temporarily store it to reduce muscular requirements. Lactic acid is a byproduct of the anaerobic metabolism and can accumulate in muscles. It will then diffuse into the bloodstream. Okay. Why is this important to know? Why is it important to know how this metabolism works? And
Your
when,
body's functioning.
yeah, how your body's functioning, but in what type of situation would this be very important to understand, especially with the lactic acid byproduct? Okay. We have diabetic ketoacidosis. And what else?
Lactic acidosis?
Okay, we talked about rhabdo, right? And how about this? Crush injuries. Crush injuries are very important to pay attention to because what happens if you got a patient who's being crushed by something and you lift up that object too fast? Anaerobic metabolism, byproduct of lactic acid, builds up in the muscle and accumulates and has nowhere to go in the bloodstream. Therefore, pools and pools and pools.
And as soon as you release that pressure, it rushes through the entire system,
Which then does what to the body?
sends it into shock and overload.
And you kill someone, and then someone dies.
Yes.
This is a paramedic level call. They need sodium bicarbonate or calcium gluconate to help break that down and push that potassium out of the cells. Another medication that can be administered, but it requires 20 milligrams of it, is albuterol. Albuterol also helps push potassium out of cells. Lactic acid and potassium will kill somebody if in a crush injury and is released too fast. Okay, very important to pay attention. That's why I wanted to bring up crush injuries and lactic acid. All right, the respiratory system anatomy. The respiratory system consists of all structures of the body that contribute to respiration. We already hit a lot of this already, so we'll kind of fly through this one here. Includes the nose, mouth, tongue, jaw, oral cavity, larynx, and pharynx. Sounds are created as air is forced past the vocal cords, which creates sound and words. The tongue is attached to the mandible and hyoid bone, okay, located up in here. The palate forms the roof of the mouth and separates the oropharynx and nasopharynx, right? Naso and oropharynx located down here, located in the pharynx, which is this area right here, right? The larynx is typically the lateral borders of the glottic, or glottis, are the vocal cords. The larynx is typically considered the dividing line between the upper and lower airway, okay? So here, upper, lower airway. The nose and mouth lead to the oropharynx, the nostrils lead to the nasopharynx. The olfactory receptors located in the epithelium of the nasal cavity are responsible for recognizing odors. Okay, we also have an olfactory nerve as well, one of the 12 cranial nerves. The esophagus and the trachea are located at the bottom of the pharynx. The epiglottis is a leaf-shaped valve that allows air to pass into the trachea but prevents food and liquid from entering the trachea itself. And the thyroid cartilage is the anterior part of the larynx, located here. The cricoid cartilage and thyroid cartilage and the cricothyroid membrane being in between. Right? As it breaks down even more, we look at how it goes down the main stem bronchi, right, to the right and left bronchi, main stem right and left, into the bronchioles. The bronchioles then break into the alveoli, which are these air-filled sacs. Okay? So in these air-filled sacs, the alveoli, what helps it keep its elasticity? What chemical keeps its elasticity to allow it to expand and contract? This is all basic level material. Remember what it is? Any ideas? Thoughts? Begins with an S.
Surfactant.
Surfactant. Excellent. Good job. So surfactant. If we have a lack of surfactant, what happens to the alveoli? Because gas exchange cannot happen if the alveoli don't have surfactant, and then causes them to collapse. What is another name for alveolar collapse? We're getting there. We're a little more than halfway through. So alveolar collapse would be atelectasis. All right, so the lungs surrounded by a membrane of connective tissue known as the pleura. The pleural space exists between the visceral and parietal pleura. All right, moving forward from here. The potential space on the pleural space exists between those two. The muscles of breathing, the primary muscle is the diaphragm. The diaphragm is unique because it is characteristics of voluntary, which is skeletal, and involuntary, which is smooth muscles. The diaphragm performs an automatic function, which other muscles involved in breathing and are the intercostal muscles and the abdominal muscles and the pectoral muscles help in that process. During inhalation, the diaphragm and intercostal muscles contract. During exhalation, the diaphragm of the intercostal muscles relax. You will probably see that again on an exam. The process of breathing is typically easy and requires little muscular effort. However, now we throw in the wrench. Chronic bronchitis results in overgrowth of the airway mucus glands and excess secretion of mucus. So now you have a buildup of mucus. We'll cover more of that in respiratory emergencies. Emphysema results in the destruction of alveolar walls, which creates resistance and expiratory airflow. That's your chronic obstructive pulmonary disease. Looking at the different muscles that we have within our system, remember we have which ones? We have skeletal muscle, smooth muscle, and cardiac muscle. Out of those three, when one of those muscles are dead, they can no longer rejuvenate. Which one is it? Yep, cardiac. Yep, cardiac muscle. Once it's dead, it does not come back. The other muscles can. Skeletal and smooth muscles can rejuvenate. All right. So the primary function of the respiratory system is to exchange gases at the pulmonary capillary membrane or to conduct respiration. Respiration is the diffusion which is the process of which a gas dissolves into a liquid. Oxygenated blood then enters the left side of the heart and is pumped into the tissues. Because there are so many alveoli, a fairly large surface area exists for respiratory exchange to occur. Right? So this figure here is showing the oxygen exchange which occurring in the capillaries of the lungs, which we already hit that quite a bit already today. As it passes through the blood into the tissues, and the carbon dioxide is passed through the tissues back into the blood, right? And at that point in time, we expel, and then that's our exhalation at that point. So the chemical control of breathing is where the brain automatically controls the breathing at this point, where the respiratory center and the brainstem controls. The main respiratory stimulus is accumulation of carbon dioxide in the blood, which then says, hey, you need to start breathing again. Breath goes back out, breath goes back in. It's all based on carbon dioxide. The low blood oxygen levels also stimulate breathing as well. So a decrease in the pH of the arterial blood that is caused by an elevation in the PaCO2 is called the primary respiratory acidosis. An increase in the pH of blood that is caused by excessive exhalation of CO2 is called primary respiratory alkalosis. So changes in the PaCO2 may occur in response to primary metabolic problems. These are called compensatory changes, right? The body also has a backup system to control respiration, and that's called a hypoxic drive. On that Sunday, I will show you guys how to figure out the difference between respiratory and metabolic acidosis and alkalosis based on looking at numbers and using a tic-tac-toe board. This is our acid, our pH, okay? We run at 7.35 to 7.45. We're always a little alkalotic, okay? We're a little higher, more towards the basic side of stuff. That's kind of where we sit. The buffer system is a compound that can repeatedly neutralize excess acid or bases. Our buffer system absorbs hydrogen ions when they are in excess and donate hydrogen ions when they are depleted. Our buffer system runs on sodium or bicarbonate. Our normal range for bicarbonate is 22 to 26. Right, that's our normal range. Anything outside of that would make it a metabolic issue. So concentrations of positive or H ions can be increased by adding more hydrogen ions to the solution or by removing OH ions. To make a solution more acidic, a higher concentration of hydrogen and lower concentration of OH are needed. If the solution needs to be more basic, meaning increasing pH level, there are two options: decrease the amount of H or increase the amount of OH. That's our two options that we have. The only thing that we can do in the field for AEMT is, one, we can give fluids, or two, we can give oxygen to kind of assist with that. We don't have the ability of calcium gluconate or other medications that paramedics should be utilizing. Acids comes to be classified as a strong or weak, depending on how completely they dissolve in water. So to function properly, acid-base balance must exist on both sides of the cell, right? We have to be able to test that somehow in the field to kind of have a better idea of what's going. The best way to do it, obviously, and this is not within any scope of practice that we have, is getting a ABG, arterial blood gas. So an increase in extracellular hydrogen ions result in acidosis, where a decrease in extracellular hydrogen ions result in alkalosis. I will show you guys an easier way to understand this on that Sunday. So there are three main components of the buffer system in the body. The circulating bicarbonate buffer component, which holds and neutralizes excess acids, found in ICF and ECF, is the fastest acting segment of the buffer system. Carbonic acid, which is H2CO3, is a weak acid that can give up an extra hydrogen ion to reform as bicarbonate ion HCO3, which is called bicarb. the other name for bicarb. The extra H ion is then converted into compounds that is easily expelled from the body, eliminating the extra acids. So here comes the respiratory component of this. The fastest way for the body to get rid of excess H ions is to create water and carbon dioxide, which can be expelled in a gas from the lungs. Exhalation. The renal component of this, the kidneys maintain homeostasis by retaining certain products and filtering others out. This could take from hours to days to restore the body's pH to normal, which then in turn can control the increase in acid levels in the blood by excreting the acid through urine. Okay, but this can take a little bit longer. All right, so the nervous system controls the breathing. The medulla oblongata is primarily responsible for initiating the ventilation cycle and is primarily stimulated by high carbon dioxide levels. All right, this is what stimulates our respiratory drive. The medulla has two main portions that control breathing: the dorsal respiratory group, the DRG, and the ventral respiratory group, which is called the VRG. The DRG is the main pacemaker for breathing and is responsible for initiating inspiration, where the VRG helps facilitate forced inspiration or expiration as needed. The pneumotaxic, or the pontine center, is located in the superior portion of the pons, which then helps shut off the DRG, resulting in shorter, faster respirations, right? The apneustic center, located in the inferior portion of the pons, stimulates the DRG, resulting in longer, slower respirations. So the Herring-Barrett reflex stops VRG, the pneumotaxic center, and the apneustic centers from accidentally causing lung trauma, right? So if you look in when you get your books, table 7.6, that'll summarize the nervous system functions regarding respiration itself. As far as lung volumes go, tidal volume is the amount of air that is moved into or out of the lungs during a single breath. Inspiratory reserve volume is the deepest breath you can take after a normal breath. As you can see, tidal volume of 500 being here. This is our inspiratory reserve is 3,000, residual 12,000, sorry, 1,200, 3,000, 1,200, and expiratory reserve 1,200, right? This is important for us to know, especially when we're doing ventilations and how we're going to help the patient breathe. Expiratory reserve volume is the maximum amount of air that you can forcibly breathe out after a normal breath. Residual volume is the amount of air that remains in the lungs to keep them open, right? Then we have our dead space, which kind of sits in our upper airway. So vital capacity, the amount of air moved in and out of the lungs with maximum inspiration and expiration. So what can we do to measure this? What can we utilize to measure all this in the field? CAPNO, exactly. So dead space, we talked about the portion of the respiratory system that has no alveoli. That is going to be your upper airway, kind of the dead space that kind of sits there. So the amount of air that moves, minute volume, is the amount of air that moves in and out of the lungs in 1 minute minus the dead space that's there. So characteristics of normal breathing: normal rate and depth, tidal volume. Remember, adults, 12 to 20 breaths a minute, 15 to 30 for pediatrics, 25 to 50 for pediatrics. Children are 15 to 30. I had that backwards, sorry. Regular rhythm and pattern of inhalation and exhalation. Good audible breath sounds on both sides of the chest. Regular rise and fall movement on both sides of the chest and movement of the abdomen. This is normal breathing. We have to assess all of this to make sure they are breathing adequately. All right, so the circulatory system is a complex arrangement of tubes connected to one another and to a pump. Kind of like a fire truck, no different, right? The pump. As known as the cardiovascular system, which is entirely closed, there are two circuits in the body: systemic circulation in the body and pulmonary circulation in the lungs. This helps oxygenate our system. Round and round it goes. Deoxygenated blood comes in through the right atria to the right ventricle into the lungs, right? Gas exchange happens. Oxygenated blood then goes through the pulmonary system into the left atria, left ventricle, pumps out to the body. Cellular exchange happens, carbon dioxide out, oxygen into the cells. Things are starting to perfuse. It comes back through again, right? That's our cardiac cycle. This is how things work. We have to oxygenate appropriately. If there's a deviation somewhere, we're going to see decrease in pulse oximetry. We're going to see changes in skin color. A lot of things are going to be there in patients that are in shock or severe respiratory distress. The heart is a muscular organ that pumps blood throughout the body, located behind the sternum about the size of a closed fist, right? Approximately 2/3 of the heart lies in the left part of the mediastinum. The heart muscle is called the myocardium. The pericardium, or the pericardial sac, is a thick, fibrous membrane that surrounds the heart and the bases of the great vessels. The visceral layer of the pericardium lies closely against the heart and is also called the epicardium. The second layer is the pericardium. Is separated from the visceral layer by a small amount of pericardial fluid that reduces friction within the pericardial sac. Right, the endocardium is the interior lining of the heart, So looking at this as a whole, we have our different layers of the heart. If I said, just lost my train of thought. Hold on a second. If a patient had pericardial tamponade, what would you see and what is that called?
Is that another way of saying AFib? No, JVD. Never mind.
Yep, so jugular vein distension is one. There's two other indicators for pericardial tamponade. Jugular vein distension and I should ask you this then. What is pericardial tamponade? So Beck's triad, okay? The pericardial tamponade is an increased fluid in the sac, right? Causing the heart not to pump correctly. It's called Beck's triad. The first thing you're going to see is jugular vein distension. The second thing you're going to see is muffled heart sounds. And the third thing is what they call narrowing pulse pressures. What I mean by that is your systolic and diastolic blood pressure are very close together. So I could say, like say, a systolic blood pressure of 80 and a diastolic blood pressure of 78. So it's called narrowing pulse pressures with muffled heart tones, and JVD is Beck's triad for pericardial tamponade. These patients need intervention quickly, and the only intervention is it's done in the ORs, or they can do it in the ER as well. It's called a pericardial centesis. They take a massive, like, long needle, go into the pericardium, pull the fluid out. Right? You gotta be able to pick up on that kind of stuff in the field if you see it. All right, this figure shows the anatomy of the heart. All right, so the heart valves, there are 4 valves of the heart. What are they? So we have 4 valves, not the 4 chambers. There are 4 different valves of the heart. It consists of flap called cusps. There are 2 atrioventricular valves separate the atrial and ventricles, and the aortic and pulmonic valves divide the heart from the aorta and the pulmonary artery. So the way to remember it is TPMA. So you have tricuspid pulmonic, mitral, aortic, right? So we're all adults. Toilet paper my ass. We remember it. TPMA. Good thing to remember that. Different heart valves. Need to know what those are. Very important. So with the heart, superior vena cava and the inferior vena cava return deoxygenated blood from the body to the right atrium. Freshly oxygenated blood is returned to the left atrium through the pulmonary veins. Okay? The pulmonary vein is the only vein that carries oxygenated blood. You might see that on a test. Blood then flows through the mitral valve into the left ventricle, which then pumps the oxygenated blood throughout the aortic valve into the aorta and then out to the entire body. The left ventricle is the strongest and largest of the 4 cardiac chambers. All right. So when we start talking about the electrical conduction system, when you feel your pulse and you feel the beat, that is your left ventricle contracting, forcing the blood out through the body. So heart sounds are created by contractions and relaxation of the heart flow and blood. We should be hearing S1, S2 sounds. So these can be heard during auscultation with a stethoscope. The lub is the first sound, which is S1, and the dub is considered S2. So it should be lub dub, right? S3 and S4 are not usually heard in people with normal heart functions, right? There are 4 other sounds, all abnormal, may be heard when auscultating the heart and great vessels. A heart murmur is abnormal, which is a whooshing sound heard over the heart that indicates a turbulent blood flow with the heart. A bruit is a abnormal whooshing sound heard over the main blood vessel that indicates turbulent blood flow within the blood vessel, and both clicks and snaps indicate abnormal cardiac valve function. Right? If you document heart sounds, right, or listen to heart sounds, you want to make sure that you're listening in a very quiet environment. The back of the ambulance down the road, there's no way you're going to be able to hear the heart sounds appropriately. Right? As far as the electrical conduction system goes, there's mechanical pumping action of the heart that occurs in response to electrical stimulus. This is what helps pump our heart. Right? We have the fluid inside, we have the vasculature, but we have to have an electrical conduction system to push that fluid out. The brain primarily controls the heart's rate and strength of contractions by the autonomic nervous system. Contractions are initiated within the heart itself in a group of complex electrical tissues that are part of the conduction system. Let's break that down. All right, the cardiac conduction system consists of 6 parts. The first one is a sinoatrial node, the SA node. The SA node has an intrinsic rate of 60 to 100 beats per minute. Then you have the AV node, which is the atrioventricular node, which has an intrinsic rate of 40 to 60 beats per minute. Then you have the bundle of His, which then in turn branches it down to the right and left bundle branches, which they'll go into the Purkinje fibers, which have an intrinsic rate of 15 to 20 or 15 to 30 beats per minute, depending on what book that you read. The sinoatrial node is a normal site of the origin of the electrical impulse. That is our primary functioning generator to our hearts. The impulse was then traveled through the atrioventricular node. An electrical stimulation of the heart muscles then continues toward the bundle of His, down each bundle branch, right and left, which terminates in the Purkinje fibers, allowing for full electrical conduction of the heart. So the heart's chronotropic state, dromotropic state, and inotropic state are provided by the brain via the autonomic nervous system. Right? The baroreceptors respond to change in pressure, usually within the heart or the main arteries. The chemoreceptors sense change in chemical composition of the blood. So with stimulation of receptors often cause activation of either the parasympathetic or the sympathetic branches of the autonomic nervous system, right? Which is affecting both the heart rate and contractility. Alpha effects result in vasoconstriction, where beta effects result in increased inotropic, dromotropic, and chronotropic states. So the way to remember this, alpha is vasculature, beta is rate, all right? Now, there's beta 1 receptors and there's beta 2 receptors. Beta 2 has to do with lungs. 2 lungs, beta 2. Beta 1 has to do with heart. You have 1 heart. All right. So beta 1 is rate, or beta is rate, alpha is vasculature. So vasodilation, vasoconstriction. Beta 1 has to do with heart rates and things like that. The process in which creates the pumping effect is the cardiac cycle, where you have systole and diastole, and also pulse pressures, which is the difference between the diastolic and systolic pressure, which we already covered. A lot of this is basic review. Afterload is the pressure in the aorta against the wall, which the left ventricle must pump blood, right? And the greater the afterload, the harder it is for the ventricle to eject blood into the aorta, reducing stroke volume. And cardiac output is the amount of blood pumped through the circulatory system in 1 minute. Why is it important to understand preload and afterload? I'll give you guys a really quick one because I know it's getting late. All right. A patient having a heart attack on the inferior wall of the heart may have what they call right side heart involvement. With this, the patient has a preload problem, which means they're not getting enough fluid. Okay. If they're not receiving enough fluid, that's going to cause the heart to have infarct. The treatment for that is not going to be nitrates. Even though they have chest pain, we still give them the 324 aspirin. If you give someone having a right-sided MI nitro, you will kill them. You will vasodilate when they already have a low preload problem, low fluid, and you're going to dump out their system. The blood pressures are going to tank, and they're not going to be able to recuperate. These patients need fluid, aspirin and fluid, versus a patient having a lateral MI or having a septal whatever heart attack. Those patients probably need nitrates. They're going to be more hypertensive, right? That's why it's so important to get 12 leads prior to giving anything with nitrates, right? To make sure it's not a right-sided or an inferior wall MI. Is that new information to anybody? Perfect. You guys already heard this before. I like it. All right. So Starling law of the heart increases venous return to the heart, stretches the ventricles, resulting in increased cardiac contractility. The ejection fraction, which is the percentage of blood pumped out of the left ventricle after each contraction. We normally, all of us, unless we have cardiac issues, usually have an ejection fraction about 70%, right? We're 100% still in the womb. Once we come out, we lose percentages right away, right? Patients that have significant cardiac involvement, I've taken patients out of hospitals for transfers with ejection fractions of 10 to 15%. These patients have no cardiac output at this point. These patients here usually need heart transplants and things like that. All right, vascular system, blood is transported through the body in the arteries and the veins. Arteries branch into many small arterioles and then divide further into capillaries. So to break it down really quick, arteries, arterioles, capillaries, venules, veins, back around again. Very basic review. The walls of the blood vessels are composed of 3 layers of tissue, smooth, thin, and interlaying, called the tunica intima, the endothelium. The middle layer is the tunica media, composed of elastic tissue and smooth muscle cells, and the outer layer of tissue is called the tunica adventia, which consists of elastic and fibrous connective tissue, as you can see here. As far as circulation of the heart goes, supplied via the coronary arteries, emanates from the left and right coronary arteries. To the right coronary artery divides into 9 important branches. The left main coronary artery is the largest and shortest of the myocardial blood vessels, which divides into 2 branches called the LAD, left anterior descending, and the circumflex coronary arteries. I will show you guys again on the 30th something else as well with 12 leads. When you look at a 12 lead EKG really quick, you can tell which artery is actually being affected by where the elevation is located. All right, and here's the main coronary artery supply of the blood, as you can see here in these photos. As far as pulmonary circulation goes, this carries the blood within the body from the right side of the heart to the lungs and back to the left side of the heart. Deoxygenated blood from the right ventricle is pumped through the pulmonic valve into the pulmonary artery. Right? So you can see this artery, pulmonary artery, carries deoxygenated blood, where the pulmonary vein carries oxygenated blood, but the rest of the body, veins are deoxygenated and arteries are oxygenated through. As far as the systemic arterial circulation, oxygenated blood then leaves the heart through the aortic valve, passes into the aorta, where the ascending aorta then arises from the left ventricle and consists of only two branches, right and left coronary arteries. There are three major arteries from the aortic arch. All right. First one is the brachiocephalic artery, which is the left common carotid artery, and the left subclavian artery. The descending aorta is the largest portion of the aorta, which is subdivided into the thoracic aorta and the abdominal aorta. If you guys can read that, more power to you. We're just going to keep running through till 10, so make sure you get the rest of these slides in. If you guys got to take a break or whatever, just step off, come back. I'm going to keep moving through. As you can see, all the different arteries and major veins, it is so small on my screen, I can't see any of those at all. Understanding vein locations are very important, especially since you guys are going to become AEMTs, and vascular access is something that we're going to have to find. And understanding the layout will help you locate the veins where you need to actually do your intravenous access. So the vascular system, the head and neck, you have the brachiocephalic artery, which is the first vessel to branch from the aortic arch, which is right here. Each common carotid artery branches at the angle of the mandible into the internal and external carotid arteries. This point of division is called the carotid bifurcation. A bifurcation is where one branches in the two. And you'll see bifurcations, even if you look at like hand veins and everything else, you'll see what things start to bifurcate as well. Looking at the upper extremity, you have the subclavian artery, axillary artery, and brachial arteries coming down through. You guys should already know most of those anyways from BLS. The thoracic artery made up of the visceral arteries and their parietal arteries as well. Visceral arteries supply blood flow to the thoracic organs. The intercostal arteries branch into the anterior and posterior intercostal arteries, and the anterior intercostal arteries originate as branches from the subclavian system. And the posterior intercostal arteries arise directly from the aorta. So more of the vascular system here, the abdominal aorta. Branches of the abdominal aorta are divided into visceral and parietal portions, as you can see through here. We're never going to know what's been severed. What we need to look for, though, as part of the vascular system goes, as far as assessment, is palpating the abdomen, looking for it to be rigid, and see if there's any type of internal bleeding. So the pelvis and lower extremities. At the level of the fifth lumbar vertebra, aorta divides into two common iliac arteries. The external iliac artery becomes the first femoral artery, becomes the femoral arteries. Femoral artery then becomes the popliteal artery in the lower thigh. And at the foot, the anterior tibial artery becomes the dorsalis pedis artery. And the plantar arteries then arise from the posterior tibial artery. So you'll see it kind of works its way down to the foot to get that oxygenated blood down to the lower extremities. All right. So the systemic venous circulation, as far as the head and neck. There are two major veins that are external, are the external and internal jugular veins. Right, the external jugular is where paramedics would utilize what they call an EJ to do it, like intravenous access. For the internal jugular veins, we would not be doing that too. Spaces between membranes surrounding the brain form a venous sinuses. The thorax. So the venous drainage begins at the anterior posterior intercostal veins, and which provide the major source of flow into the superior vena cava. The abdomen and pelvis, all venous drainage from the lower part of the body passes through the inferior vena cava. The internal iliac veins then drain the pelvis, and the external iliac veins then drain the lower limbs. The hepatic portal system is a specialized part of the venous system that drains blood from the liver, stomach, intestines, and the spleen. And then blood then empties into the hepatic veins, which then joins the inferior vena cava. So as you can see, one big circulatory system. As far as the veins go, the upper veins of the extremity vary somewhat from person to person, but having a rough idea, like the AC vein locating down here, we've done brachial vein access, cephalic vein runs through here. That's more of your lateral aspect of the arm. We don't do anything with subclavian vein unless we're doing something with an IO. If you do interosseous access, the subclavian vein goes through. It's almost like a central line to the heart. That's why IO access in the shoulders are in theory better. Problem is that that's also a bad location when doing CPR and airway management because you're kind of in the way up there as well. As far as blood composition goes, there's 55% plasma, 92% water, 8% dissolved substances, protein, electrolyte, nutrients, 45% cells suspended in plasma, like white and red blood cells, platelets, things like that. We're never going to measure any of these in the field. If you do an interfacility transport, you'll probably see something called the CBC, which is a complete blood count, where you'll have all these different things for you. So red blood cells carry oxygen, and white blood cells, also known as leukocytes, play a role in allergic and inflammatory reactions. Also, patients that have an infection will also have an increased white blood cell count. Platelets are necessary for chemical reactions that occur to form clotting, right? So you want to make sure that patients have platelets. Patients can have different clotting diseases and lack like factor VIII, different factors of the blood that make it so the patient can no longer clot. Ones that know that, they know that they're hemophiliacs and things like that, they can no longer clot anymore than what you know. What's another medication out there that can cause blood to thin? Blood thinning. So aspirin is a platelet aggregator that makes platelets less sticky, but does not actually thin the blood. Lasix is a diuretic for urination, removing fluid.
Talking about like Coumadin, warfarin type stuff.
That's it. Coumadin, warfarin, heparin is another one they utilize as well for STEMIs in the field. But yeah, patients on Coumadin, warfarin, Xarelto, all those different medications. So why is that important? Yep, another one, Mike, as well. So why is that so important to know?
I mean, if you're going for access and you blow a vein, blow a line, something, you.
Yep. How about a head trauma? Patient that fell.
Oh yeah.
Right? So the need for TXA. Yeah, Mike, you're absolutely correct. Unless it has to do with head trauma. We don't want to get TXA for head, but anything else, you're right. Internal bleeding. TXA will be great. Tranexamic acid. Which, by the way, is not an A skill. Then it's the paramedic med. Right? So it's good to have an understanding how this stuff works. Red blood cells also contain antigens on their surface, which stimulate the formation of antibodies. There's different blood types that are out there. Determine on which types of blood persons can receive. So you can either have A, B, or O. It can be positive, negative, They can also be, excuse me. So antigens are substances that will take into the body, stimulate the formation of specific protective proteins called antibodies. So we'll go a little more and have an idea of how this stuff actually works. So this is classified as ABO blood groups. These groups determine which type of blood a person can receive. A person with O type blood is called a universal donor, or a person with AB blood is called a universal recipient. A person can have an Rh factor, which is a specific type of Rh antigen presented in the blood or not. The presence of Rh factors must also be considered during blood administration. Nothing that we're going to be doing at all in the field. With the circulatory system, the pulse is created by blood pumping out of the left ventricle into major arteries, which we've already covered. So we have the external maxillary, superficial temporal pulse, carotid pulses. We have brachial, ulnoradial pulses, femoral pulses. Out behind the knee is what they call popliteal. We have the posterior tibial pulse, and the dorsal pedal pulse. If you find these down here in a patient assessment, make an X with a pen or a marker of some sort so you know where to find it again. So they can be kind of tricky, especially if the patient starts losing circulation. So mark your stuff. Systemic vascular resistance refers to how dilated, constricted blood vessels are. The average adult, we talked about already, has 5 liters of blood. Normal circulation in adults, let's see. So the circulatory system normally adjusts and readjusts automatically. Now, we can have deviation. So loss of normal blood pressure is indication that blood is no longer circulating efficiently to every organ of the body. Shock is a state of inadequate circulation involving the entire body, which we want to make sure we can prevent. So vital signs. The patient is unstable every 5 minutes. Stable patients every 15. Right? It's all BLS stuff that we're talking about. They'll help you keep these patients alive. So again, reassess vitals. If you have low blood pressure, put a line in. Keep in mind, get lines early. Get IVs early in the patient contact and assessment, because once they start bleeding out, they start losing vasculature, which makes it harder to do an IV. So the heart automatically adjusts to low blood volumes as the patient loses blood, right? So if we're losing blood, we become tachycardic in hopes to maintain homeostasis. What is the first organ to shut down the patient who's going into shock? What is the first organ to shut down in a patient that is going into shock? So one of the complaints you're going to have in a patient who's hypovolemic or losing blood is they're going to start saying they're nauseous. So you're going to think, oh, maybe we should give them some Zofran, which is within your scope of practice. What they really need is fluids to relieve the nausea, because the stomach is the first organ to shut down. And because of that, they're going to start getting nauseous. So as far as the function of blood, most blood is unevenly distributed throughout the body. Approximately 30% of blood is found within the heart, arteries, and capillaries. 70% of blood is found within the veins and venules. As far as the function of blood, we've already talked about this here, which as far as deoxygenated, oxygenated blood going back through, making sure that the cellular level is becoming oxygenated appropriately, and also getting rid of the all right. So lymphatic system is, excuse me, is a thin plasma-like fluid formed from interstitial fluid, or ECF. The lymph circulates through the blood in a thin-walled lymph vessel, where foreign material is filtered from the lymph. It's kind of like our septic system, like we get rid of all the bad stuff in the lymph nodes, and returns to the main circulatory system via the thoracic duct. Did I lose anybody yet? We're almost there. All right. Yeah, we're getting there. We're probably about 30 slides left. We're moving pretty quickly through the rest of these anyways. So lymphatic vessels only carry fluid away from the tissues, nothing towards it. Lymphatic capillaries are present in all tissues except the central nervous system, bone marrow, cartilage, epidermis, and the cornea as well. The central nervous system is the most complex organ system within the body, composed of the brain, spinal cord, and thousands of nerves. Divided into the central and peripheral systems. The somatic nervous system is part of the peripheral nervous system that regulates activities over which is voluntary control, like walking and talking. The autonomic nervous system controls many body functions that occur without voluntary control. So the central nervous system, with the brain, is controlling the organ of the body, center of consciousness, and three major subdivisions of the brain: the cerebrum, the cerebellum, and the brainstem. The cerebrum is the largest part of the brain, called the gray matter, composed of 4 lobes: frontal, parietal, temporal, and occipital. The brain brain cells in the area generate impulses that are sent along nerve fibers that extend from each cell into the spinal cord. The cerebellum, which is called the athlete's brain, coordinates various activities of the body, particularly body movement, like the brainstem. Most primitive part of the central nervous system. It's best protected part of the CNS, and comprised of 3 different areas: the midbrain, the pons, and the medulla oblongata. The reticular activating system, or the RAS, is in the midbrain, which keeps you conscious. The spinal cord, which is an extension of the brainstem, contains nerve cell bodies as well, and nerve fibers, which transfer information to and from the brain. So if you touch something and it hurts, it transmits that message. The principal function is to transmit messages between the brain and the body. Hot, cold, things like that. The meninges, which enclose the entire CNS, is by a set of 3 tough membranes known as the dura mater, arachnoid, and pia mater, which then float in cerebral spinal fluid, which is manufactured by cells within the chordate plexus in the ventricles. Areas normally as interconnected as CSF flow freely within the subarachnoid space. So something to think about with that as well. Where our brain kind of sits is surrounded by fluids. When we start getting more into head trauma, we'll talk about CTE and different things that they have found as well with that. The limbic system influences emotions, motivation, mood, and sensations of the pain and pleasure through the brain. So it's a good idea to kind of have an understanding where these things are located. So when you're talking to a patient and they don't feel any kind of pain or they don't feel any kind of pleasure, they've had different changes, things like that could inhibit those would be like, tumors and things like that within the brain as well. The peripheral nervous system, composed of cables and nerve fibers, divided into 2 portions: somatic and the autonomic nervous system. The autonomic has 2 different systems within that, one being the sympathetic, which is the fight or flight, and the parasympathetic, which used to be called the feed or breed, which actually slows down the body. And there are 2 different types of systems within the peripheral nervous system: sensory and motor, which we'll get more into when we start talking about neurosystems. These are the 12 cranial nerves. Take a look at these here, and then you'll probably see some of these as well in the quiz. But I'll go through them really, really quick, though, as far as the names go. So we'll go 1 through 12. Olfactory nerve, which provides a sense of smell. The optic nerve provides a sense of vision. Oculomotor nerve innervates the muscles that cause motion of the eyeballs and upper lid. The trochlear nerve innervates the superior oblique muscles of the eyeball. Trigeminal nerve supplies sensation to the scalp, forehead, face, lower jaw, and the 3 branches as well. The abducens nerve supplies the lateral rectus muscle of the eyeball. Facial nerve supplies obviously motor and activity to the muscles of the facial expression. Vestibulocochlear nerve passes through the internal auditory medius and provides sense of hearing and balance. The glossopharyngeal nerve supplies motor fibers to the pharyngeal muscles. The 10th cranial nerve, which is the one that we deal a lot with, is called the vagus nerve, and vagal stimulation can cause heart rates to drop, things like that. Usually what happens if someone's bearing down, like going to the bathroom, they can drop their heart rate down. That's why we see a lot of time with the elderly, we see what we call commode codes, where they have tried to bear down because they are so constipated, they actually stimulate vagus nerve response. The spinal accessory nerve provides motor innervation to the muscles of the soft palate, the pharynx. And the last one is the hypoglossal nerve, which provides motor functions to the muscles and tongue of the throat. That's why it's so important to have an understanding of these as well, of where they're located. Dermatomes are pretty good to have an understanding about as well, which area of the skin that corresponds to certain spinal nerves. So we do different testing. Like if I poke down here, you should be able to feel pain as well moving through. So this is more of your dermatome. We'll cover more of that in, again, neurology. As far as the eyeball is called the globe. The inner surface of the eyeball is exposed to the surface of the eye itself, are covered by a delicate membrane. The conjunctiva and keep moist by fluid produced by the lacrimal glands. So behind that we have the iris, which is the lens, and the lens focuses on images on the retina itself. All right, the integumentary system, this here is truly basic review, plays a crucial role in maintaining the consistency of the body. This is also our major layer of protection. The skin is divided into two parts, the epidermis, which is superficial, the dermis, which is deeper through the skin, and we have what they call the subcutaneous, which is the lower part of the skin down here, subcutaneous fat tissues. The integumentary system serves three major functions: protects the body, regulates body temp, and transmits information from the body or from the environment to the brain. So if you had an injury to the skin, let's say it's severe burns, that could make it so your body can no longer regulate temperature in that area or whatnot. That's why burn patients can become hypothermic very quickly with that. The digestive system, also called the gastrointestinal system, is composed of the gastrointestinal tract, stomach, intestines, mouth, salivary glands, pharynx, esophagus, liver, gallbladder, pancreas, rectum, and anus. With that, digestion is the process of food that nourishes individual cells in the body. Almost there. This contains major organs of digestion and excretion divided into four quadrants. We have the right and left upper, right and left lower quadrant. The urinary bladder lies just behind the pubic symphysis in the middle of the abdomen, therefore lies in both lower quadrants and in the pelvis. The kidneys lie retroperitoneum, it's a retroperitoneal space, so out behind. So if you have a patient that's having extreme pain in the back, more so one side than the other, apply pressure and see if you have any increased pain. Any troubles urination, it potentially could be renal colic or a kidney stone. So again, understand where the kidneys are located on palpation when you're doing your assessment. The mouth consists of lips, cheeks, gums, and the tongue. And mucous membranes lies between the mouth. Remember that mucous membranes are very important to be able to assess, to see changes in color. The oropharynx extends vertically from the back of the mouth to the esophagus and the trachea, and the esophagus extends from the end of the pharynx into the stomach. And a lot of this stuff's to review. The stomach is located in the left lower quadrant of the abdominal cavity, largely protected by the lower left ribs. The pancreas, which is a flat solid organ below and behind the liver of the stomach and behind the peritoneum, which contains two glands, the exocrine and the endocrine glands. This is where pancreatic juice contains enzymes in the exocrine part of it, which help digest fat, starch, and proteins. where the endocrine glands are the islets of Langerhans, where insulin is produced to help with sugar as well, help excrete the sugar and break it down. The liver is a large solid organ that takes up most of the area and immediately behind or beneath the diaphragm in the right upper quadrant. Also extends in the left lower quadrant. Those poisonous substances produced by digestion and rendered harmless in the liver, but outside of it can cause significant infection. The gallbladder serves as a reservoir and concentrating organ for bile product of the liver as well. The small intestine composed of the duodenum, jejunum, and ileum. Those are products of digestion are absorbed into veins to be transported to the liver itself, where the large intestine consists of the cecum, the colon, and the rectum, which absorbs its final 5 to 10% of digested food and water to form solid stool. Right? Almost there. Almost there. The appendix, which is a tube of 3 to 4 inches, 8 to 10 centimeters long, that opens into the cecum in the right lower quadrant of the abdomen, may easily become obstructed as a result, inflamed and infected. What was that name that we call the location of the appendix? What point was that? Do you guys remember that from last class? Remember that one? We're almost done.
McBurney's point.
Perfect. Thank you. Thank you. All right. So digestion is the complicated chemical process where different secretions, primarily enzymes, are added by food or to food by salivary glands, stomach, liver, pancreas, small intestines. And converts food into basic sugars, fatty acids, and amino acids. Almost there. 12 more to go. We'll be done. The endocrine system, obviously, the complex message and control system that integrates many bodily functions. We talked about this already. Endocrine glands excrete chemicals in elimination, where the endocrine glands secrete and release chemicals that are used inside the body to help break down those sugars, the insulin. Hormone regulated many body functions as well through this endocrine system. An agonist is a molecule that binds to a cell receptor and triggers a response by that cell. An antagonist is a module that binds to a cell's receptor and blocks the action of an antagonist. Pituitary glands and hypothalamus. Pituitary glands often referred to as a master gland, where the hypothalamus gland is a small region of the brain, not a gland, that regulates the function of the pituitary gland, primary link between the endocrine system and the nervous system. So that's why it's so important. The thyroid gland is a large gland on the base of the neck, which manufactures and secretes hormones that have a role in growth, development, and metabolism. This secretes calcitonin, which then helps also maintain normal calcium levels in the blood. And the parathyroid gland, embedded in the posterior portion of each lobe of the thyroid, produce and secrete parathyroid hormones. The pancreas is an organ that both endocrine and digestive system utilizes, where lies between the greater curvature of the stomach and the duodenum and the retroperitoneum. Within the islets of Langerhans, the alpha cells that secrete glucagon, beta cells secrete insulin, delta cells that secrete my goodness, I'm getting dry. Somatostatin. So the adrenal glands are located at the top of the kidney, where the inner portion of the glands then produce epinephrine and norepinephrine. Why is that important? Because these are norepinephrine is a neurotransmitter of the sympathetic nervous system. It helps with that whole fight or flight deal. As far as reproductive glands and hormones, the gonads are reproductive glands, ovaries in women, testes in men. Testosterone is a major androgen manufactured by the testes, and there are 3 major female hormones: are estrogen, proestrogen, and human chronic or HCG gonadotropin as well. All right. For the urinary system, obviously the kidneys are solid organs, ureters, bladders, urethra, and hollow organs. This helps control pH balance, filter eliminated waste, and control fluid balance in the body. That's why it's so important to make sure we keep these patients out of shock, because if we have having acute renal failure, these patients no longer secrete or control fluid regulation within the system. Another thing too is patients that are in the hospital that are on pressors can also reduce that as well. The kidneys rid blood of toxic waste and control balance of the water and salt. So urine passes into the renal pelvis, urinary bladder, the bladder that enters through the urethra, causing urination. Patients that haven't urinated in days, that's a significant medical emergency as well, because that can also shut down their kidneys. Those patients probably could potentially need a urinary catheter placed. Right, female genitalia are contained within the pelvis. The male genitalia lie outside the pelvic cavity, as you can see in this photo here. We can start getting reproductive system more, and we'll cover more of this stuff in detail. So we have the male reproductive system, female reproductive system. Ovaries produce sex hormones, oocytes as well. During the menstrual cycle, ovarium matures and the fertilization occurs. Fertilization egg proceeds through the fallopian tube and implants in the uterus. The thing is, though, is any female within childbearing age that has significant abdominal pain potentially could be a fallopian tube implantation or an ectopic pregnancy. Again, I'm not going to cover this stuff in detail because we're going to cover more of this during OBGYN. Right, and to finish off the body, the life support chain, remember, things have to go round and round. Food has to go in, food has to come out, and urinary output has to help remove toxins. If there is a limitation or something changes in this, whether air going in, air coming out, blood going round and round, we're going to not have homeostasis. That's why it's so important to make sure you have the proper assessment. So I do apologize. Let me shut the recording off here.